Hello, welcome everybody. See people still connecting to audio, so we'll give this a second here. Okay, welcome. This is the 13th committee meeting of the House Bill 1477 Crisis Response Improvement Strategy Committee. And I am Jamie Strauss-Clark, your facilitator. It's nice to see all your names on the screen here. I know people are still coming in. I'm going to take us through a couple of quick slides to remind everyone about the Zoom tools and how we use them so that we can be together in this digital space. Thank you. Is that Chloe or is that Chloe? Yeah, it's Chloe. I'm just checking to see who's showing the screen. I have two slides. One is for CRIS committee members and one is for our guests and community members who are joining us today. So we'll start with the CRIS committee member slide. I'm going to ask that everyone keep your mics on mute. That button is in the lower left hand corner of the toolbar. Chloe, if you could just hit the advance, it'll show. There we go. So please keep it on mute. That'll just help eliminate background noise and distractions, unless, of course, you are speaking. Click again, please. If it is available to you, especially during our discussion, it would be great, CRIS committee members, if you could keep your video cameras on. And that, of course, is available where you see that red arrow. Click ahead, please. We use raise your hand function to indicate when we want to speak. So please click on that reactions button on the far right, and then you'll see raise your hand. I think it's *6 or *9. I really need to remind myself of what that is if you're here by phone. Or as I've said before, you can wave your hands and I will do my best to track you. Also, CRIS committee members, you are welcome to communicate via chat to me if you prefer to do that. And you can do that doing the chat button that's indicated right now. Send it directly to me, Jamie Strauss-Clark. Advance one more time. If you'd like to see as many CRIS committee members on the screen as possible, you can click on that view button at the top and change to gallery view. One last thing, actually, Dylan suggested this at the last meeting, and I think it's a great one to alert you to. If you are finding that your internet is unstable, we had a couple of folks who were dealing with that last time. When you log into the meeting, you can choose to dial in rather than use internet for the audio. It may mean you won't be able to have video access, but it can help if you're finding that you're chopping up when you're speaking. And so that's a choice. If you're finding that's happening to you today, you could always log out and log back in again and use dial in for your audio. All right, one more advance. This is the set of instructions for our community members and guests. Welcome. Thank you as ever for all the time that you put into supporting this process and engaging in these meetings. We're grateful to have you here. Couple of reminders for you that are slightly different from the CRIS committee members. Again, if you could keep your mics on mute for the entire meeting, unless you're signed up to make public comment at the end, at which time I'll let you know when it's time to unmute, that would be great. I'm going to ask non-CRIS committee members to keep your video cameras off, again, because it just makes it easier for us to facilitate the conversation with CRIS committee members. The exception are staff who are presenting today, or yes, section of staff who are presenting today. Advance the button, please. As with the CRIS committee members, if you'd like to see as many members as possible, you can click on that speaker view button, change to gallery view, and you can see more members. As far as chat goes, if you're having a technical question or you'd like to sign up to make public comment at the end of the meeting, you can use the chat button to reach out to Brittany Thompson. I unfortunately am not able to receive chats from community members while I'm facilitating speaking with CRIS committee members. So if you send one to me, I'm not going to see it. You'll need to send it to Brittany Thompson. The last thing I want to mention is we have 2 ASL interpreters joining us today. They should be spotlighted on your screen. You can unspotlight them if you'd like, if you don't need that support today. but Jackie and Lori are joining us and will be switching every 15 minutes, providing ASL interpretation. I think that's it for the preamble. So if we could advance the slide. Actually, if we could stop the share, I'd like to pause and ask Joan Miller with the Washington Council for Behavioral Health to share some words of welcome today. Joan is one of our CRIS committee members.
Hello. Thank you, Jamie. And I guess welcome everyone to the May 2023 CRIS committee meeting. My name is Joan Miller. I am the CEO with the Washington Council for Behavioral Health and the provider representative on the CRIS. For those of you who don't know, the Council is the statewide association of licensed community behavioral health agencies, and our members provide a full range of community mental health services, evaluation and treatment, residential and supportive housing, and substance use disorder services for both adults and children. Our members also provide many of the current crisis response services across the state, including operating the 988 contact centers, the regional crisis lines. We provide mobile crisis outreach, ITA evaluations by designated crisis responders, and crisis triage and crisis stabilization services. Today at this meeting, we'll be tackling a place to go for people who need crisis stabilization services, and we will begin the discussion about where we have critical gaps in our system. As we'll hear about later during this meeting, the 2023 legislative session ended with significant investments in behavioral health, including funding for 23-hour crisis relief centers, crisis stabilization facilities, and children's long-term inpatient beds. One of the biggest investments made by the legislature was a 15% Medicaid rate increase, and this is going to be instrumental and foundational to stabilizing the entire continuum of behavioral health care, not just crisis services. We want to always try to remember that the goal is to actually help people sooner before they need crisis services, before they need to call the 988 line. We so appreciate the engagement of community members and professionals, and most especially people with lived experience. One of the greatest strengths of the CRIS committee is the diversity of perspectives and experiences, both personal and professional, that each of us bring to these discussions. As we explore crisis stabilization services and work together to identify system gaps, we'll be relying on each CRIS member to bring our observations and experiences to this discussion. I really value being a member of this committee, and I look forward to our work ahead improving crisis services for those who need them. Thank you.
Joan, thanks so much for setting up our day so beautifully. Appreciate it.
Of course.
At this time, we typically had, for the last several meetings, we would be moving into getting some information updates or education on tribal-centric behavioral health and crisis response. Vicki Lowe, who's the executive director of the American Indian Health Commission, and who I think you've heard from before, will be sharing information today about tribal-centric crisis stabilization, so very germane to our topic. She is not actually able to join us until later in the meeting. She's got a very busy schedule, as you can imagine. So we're going to move that item to a little bit later in our agenda, so stay tuned for that. Chloe, could you put the slides back up on the screen, please? Okay, so our main objectives today are that we do have now an updated work plan. So we're going to get grounded in where we've been, where we are now, and where we're going in this CRIS process with some late-breaking updates or new updates. We are going to hear a wrap-up of the legislative session, including the implications for 988 and crisis response improvement. And then the bulk of our discussion today is going to be focused on identifying and discussing system gaps related to crisis stabilization, a place to go, as we've referred to it, with the intent to inform HCA strategic planning, as well as, Healthcare Authority strategic planning that's coming up this June, as well as steering committee recommendations for addressing these gaps. We'll confirm action items and next steps and hear public comment. That's the slide, please. All right, so we've had some late breaking agenda changes. So this is going to look a little bit different than the agenda that was sent out to you last week. First, we typically would go from this welcome and agenda overview into our personal story. And there was a personal story planned for today focused on crisis stabilization. That has fallen through, so we are not going to have a personal story today. What we're going to do instead is move directly into our discussion of system gaps and crisis stabilization. We're going to do that until 1:45, where we're going to take a short break. Then we're going to come back and do action items and next steps. We're going to do something a little unorthodox and do our public comment period a little early today at 2 p.m. And then we're going to do the presentation and Q&A on the legislative wrap-up. That's the other late-breaking agenda item, which is, many of you are probably aware that there was a special legislative session called. And it looks like all of our legislators are on the floor today. And so we are hopeful that Senator Dingra will be able to join us around 2:15, but we do not know for sure. If she's not able to be here, Megan Zeladonia has offered to step in and share some of her insights on a couple of pieces of legislation. So we will still get some good wrap-up information, even if Senator Dingra is not able to join us, with the intent of, if we can't do all of it today, we'll do a more in-depth dive at the June meeting, and then aim to adjourn at 3. That may actually be possibly a little bit earlier given some of the changes in our schedule today. So that's what we're going through today. As I mentioned, Vicki Lowe with American Indian Health Commission will be presenting to us, and we're going to be having her presentation sometime before the break, depending on when she arrives and where we are in our discussion. Can you advance the slide, please? Okay, so we have a few updates. I think I'm going to turn this over now to Betsy to share a little more about the timeline and deliverables and changes since the session has ended. Betsy?
Sorry, had to unmute. Thanks, Jamie. Welcome, everyone. I want to give you an update on our timeline and deliverables. Given the very productive legislative session that just wrapped up, and all the behavioral health investments, we also had a change with our House Bill 1134 that extends the timeline for our CRIS process. So we have now, instead of a final report due in January 2024, we have a third progress report that's due in January 24 that includes a summary of activities completed by our CRIS committee in 2023, which also includes recommendations related to our designated 988 contact hubs. And then the extension allows for a final report in January, on January 1st of 2025. So essentially our CRIS process has been extended by a full year through the House Bill 1134 passage. Given that, I'm going to give you a couple of updates on our decision process, which the next 2 slides, and you may remember that we have been deferring on our decision process updates in the last couple of CRIS meetings because we're waiting for news about this extension. So Brittany, Chloe, can you move to the next slide? Thank you. So this is our committee decision process map with the 1-year extension, as I mentioned, that was created by House Bill 1134. Now we have our progress report due on January 1st with the final report due on January 1st of 2025. This extension allows us time to focus on areas of discussion that are needed rather than trying to get everything done in one single year. So we've essentially moved a couple of items, as you'll see, into our focus area work for 2024. This year's focus has been on crisis response, on the crisis response services continuum and the resources needed to expand. This summer, we're moving into a focus of synthesizing the discussions and recommendations that have come out of the CRIS and work group discussions this year. And it will establish the foundation of recommendations for the steering committee to consider for the January 1st, 2024 progress report. And again, it reflects more time created this year for the CRIS to deliberate and develop recommendations. So, basically in this slide, you'll see that we spent 3 months talking about someone to come. That work includes some of the work group discussion around the collaboration with first responders. And we're here today at the Crisis Stabilization Services and Gaps discussion. And then we move into service recommendations from June into August that will help us make the recommendations for the progress report in January. Next slide, please. And then the calendar allows for the development of draft recommendations in September that will feed into the writing of the report in October. So we're planning to take a break in October so that we can draft the report and then come back to you in November to get input on that draft report, and then approve the progress report in December. So essentially, this gives us more time this year for you, CRIS members, to consider recommendations and to review the draft report before it's sent to the steering committee in December to approve and submit by the January 1st deadline. And then in 2024, we're turning our attention ideally to the 2 remaining areas of focus needed. Again, not having to do all this work this year, we have the luxury of time next year to look at system goals, metrics, and oversight, and system infrastructure, that being technology, workforce, and cross-system coordination. And all of these are part of committee recommendations called for by House Bill 1477. And the focus in 24 on technology and our system infrastructure will be well timed given the RFI that has been released for our interoperability platform. So that's the update on our timeline and our progress. So Jamie, hand it back to you.
Thanks so much, Betsy. Before I move on, any questions from CRIS committee members about these changes? Okay, so one last housekeeping item before we move into our discussion, which is we do not have anyone sign up for public comment today. I am going to aim to do public comment at 2 p.m. As I mentioned when I went over the changes to the agenda. So if you are listening to the discussion today about crisis stabilization and you'd like to make a comment, this is I'm speaking specifically to members of the public who are on the call today. Please send a chat to Brittany Thompson, and we will add you to the list and take as many people as we can during the time period that we have for public comment. Okay, I think we're ready to move into our discussion, as I mentioned earlier, but for those of you who may have joined a little bit late, we are not going to have a personal story today. There was one planned, but it fell through. So we are going to move directly into our discussion. And we're going to kick that off. Senator Dhingra, actually, before we dive in, I think Senator Dhingra wanted to say a few words. We were talking about this particular topic the other day, and you were mentioning the importance of prevention and getting to a place where we work ourselves out of a job here. So do you want to say a few words about that before we move into our presentation and discussion?
Sure, absolutely. I am happy to do that. You know, we are here to do crisis work. I mean, that's literally what this committee is all about. And I do think that I'm speaking for everyone on this call, but I feel I can. I think everyone on this call would be happy to say, you know what? We would love for there to be a time where we don't have to worry about crisis work because people are getting the help they need when they need it, and they don't have to go into crisis to get that help. So sorry for speaking for everyone, but I feel I've been around all of you long enough to know that I think I'll see a lot of nods with that statement. And so while we are focused on building that crisis work, because that's where we have to be at this point in time in our community and in our state, I also want to be very mindful that the system that we're building up, it should be a system that is also available to those individuals who want to get the help and resources and the services they need when they're not in crisis. And so really making sure that infrastructure is there, but it's an infrastructure that can do preventative care when people need it, no wrong door, treatment on demand, so that in a few years, and I'm not going to put a timeline on it because I think that timeline should have been yesterday, but really saying that we shouldn't have to be here. So I think we should talk about system gaps. I think we should also be mindful that no matter what we are building out, that all of that should be doing early intervention and prevention work. And I know we didn't have a story to share today, and I apologize if I'm going off agenda, but I'll just tell you that this weekend, I got a call from my daughter's friends, a group of girls that had been together since kindergarten. And two of them were so scared because the cops had been called on the third one because she had a psychotic break. And sorry, I just realized my video is off. And, you know, I have done so much crisis work, and to be there and to see law enforcement engaging in de-escalation techniques, trying to get her to get her the help that she needed, to get her into an ambulance, and to take her to a psych hospital. You know, that is not what we want for our children, for our neighbors, for our community, to be forcefully taken to a psych hospital. But that is the reality of our system. And so I just want to again thank all of you for the work that you do and acknowledge that the goal here is to build on and work on a system that works for everybody and it provides services before they get into a crisis. So thank you.
Thank you, Senator Dhingra, and for sharing what sounds like a very heartbreaking personal experience for your family and for your children. Thank you for sharing that with us today and for setting that up. That actually echoes really closely with the words that Joan Miller shared with us at the beginning today regarding creating a system that prevents us from needing the crisis response in the first place. So with that set up, let's move into our focus today, which is system gaps in the crisis stabilization piece of our three-legged stool. Our objectives for this discussion today are first to understand, and by the way, I got a note from a CRIS committee member that I'm sounding very soft, so I'm trying to use my outdoor voice. Please let me know if you have any trouble hearing me. I'm not sure what's going on with my mic today. Our first objective is to understand what crisis stabilization services in Washington include and the current distribution of crisis stabilization services, and then together discuss and surface barriers to getting from acute crisis to crisis stabilization to inform healthcare authorities' strategic planning that's coming up for them, and also future discussions on how to address those gaps, reflecting back on the work plan that Betsy was showing you just a few moments ago. We're going to start with this by having Matt Gower from Healthcare Authority present some background on crisis stabilization services in Washington. And then I'm going to set up the discussion for CRIS committee members. So I'm going to turn it over now to Matt.
Thank you, Jamie, and thank you everyone, the CRIS committee, for having me present once again on a beautiful spring afternoon. Could you pull up the slides real quick? Thank you. Once again, just to cover what Jamie was saying, we're here to kind of talk about that third leg of someone to talk to, someone to respond, and a place to go. But this leg is a little bit different. It's not just always a place to go. Not everybody needs to leave their house. To Senator Dinger's point, a psych hospital may not be the best place for everybody at this point in time. So we wanted to kind of explain a little bit more about what stabilization services are and how they kind of cross in between all three of the someone to talk to, someone to respond, and a place to go. So next slide. Once again, this is my team that we're working on here. Wyatt Dernbach, my partner, has helped me put together this slideshow very well. And Luke Wagner, you'll hear from Sherry Wiley a little bit later on talking about the youth stabilization. Next slide. So crisis stabilization for adults. Again, trying to reiterate how adults and kids are very different, and the process we go through for them should be different. There's that transition age youth where there's a little bit of gray area, but for the most part, a 35-year-old and a 15-year-old are very different people. So the first part of this presentation will be focusing on adults, and then I'll have Sherry come back on and talk about stabilization for youth. Next slide. So the ideal continuum for a crisis would be, the first step is crisis de-escalation. In an ideal world, that would be done by a mobile rapid response. So somebody coming out to meet a person in the community where they're at, where they want to be met, and provide de-escalation right there on the spot. Another place, Senator Dinger's bill, the 5120, that's setting up crisis relief centers, that would be a place for somebody to go to if they wanted to, instead, to get that initial de-escalation. And then there are other programs, like we have on the adult side, PAC program of assertive community treatment, that provides the de-escalation for any members enrolled with them. A lot of community behavioral health agencies will also do de-escalation for members that are enrolled with them, although that typically only happens during business hours. The next step would be to stabilize them. So once you have somebody calm down, you have them kind of outside of their sympathetic nervous system, they're working and processing their emotions, you want to start putting in supports to keep them there, to keep them from going back into that escalated state. So this could be done by in-home stabilization through that mobile rapid response. It could also be done through a next day appointment. And so a lot of cases, a crisis could be related to a medication issue or the need to start services or something like that, and getting that in place can be that support that helps move them into the stabilization zone. And it can also be facility-based stabilization. So this is what a lot of people hear about on this third leg, that place to go. And this could be a crisis stabilization unit. And I'll explain these a little bit more detail here in a minute. Peer respite, withdrawal management, which is usually for substance use disorder. And it can also be inpatient, like an evaluation, treatment, or a hospital if somebody needs that level of care. And then the final step in the crisis continuum, which is really after the crisis, is if the person is connected into outpatient services, long-term social supports like supportive housing and employment, certain social services can help, but also crisis planning, which can also fit under that stabilization period, but is usually best done looking back at a crisis plan or crisis. And that's when you would do like a wellness recovery action plan or mental health advance directive. So the next time you start getting close to a crisis, you have kind of a plan to either avoid the crisis or steps to mitigate it. And then also other community supports. NAMI groups are amazing. They can help keep people well. Peer-run support groups and peer-run facilities like Peer Washington are great places for people to go to continue to get support to stay well. And that's our goal, is to keep people well after a crisis. So next slide. So crisis stabilization services, again, can run that gamut from talking to somebody on a phone to a mobile crisis team to a facility. So this is kind of that, after we get somebody out of their activated state, how do we put supports in place to keep them well and keep them out of crisis? So a lot of times we work off of personal supports. We help them develop new skills. We build on existing supports, and we do that crisis planning piece, like I mentioned. This is where we really empower people to start kind of taking control of their situation and putting the things in place and the steps they need to do to stay well. We also connect them to resources. A lot of times crisis can be caused by lack of resources, various things from housing, food, to treatment. So we want to get them into some sort of resource connection, and that can be through an outpatient intake or a next day appointment. And next slide. So again, just to reiterate that this can happen anywhere, and there's advantages to both. We don't always have to take somebody to a place for them to stabilize. That's kind of the old medical model that you always had to take somebody to a place and that's where they get well. But a lot of times people recover best and stay well in their own home when they learn the skills where they're at. They continue to go to work, they continue to go to school, they continue to interact socially, and they can practice these skills in those environments and they can stay well. Right now, our current system is set up for 14 days for stabilization for mobile crisis, but it's not like at the end of 14 days, mobile crisis will just pull away if the person's not well. We just have to kind of reopen the episode of care. But there are some downsides to it. Sometimes a person is not in a safe environment, or the environment they're in is too chaotic, or they just really need a place to go. And so that is why we have facilities to take people to, like crisis stabilization facilities. They are a safe environment to do the same stabilization skills, training. They can also do medication changes a lot easier in some cases. They can also do more focus groups and things like that because the person is there, and they can do more hands-on and intensive stabilization support. The stays are often shorter. Typically, the average stabilization stay is about 5 days to a week. Can be longer, it can be shorter, but that's kind of the difference in crisis stabilization services, is whether a person gets in home or in a facility, and it can be both. The person can be discharged from a facility, and outpatient provider or mobile crisis team continues that stabilization as they transition back to their home. So next slide. So the basic crisis facilities we have, just to orient you to that list I had mentioned a while ago, is we have crisis stabilization units. Those are 3 to 5 days, 5 to 7 days, depending on which data you pull, but they are shorter term, they're voluntary. They can do an involuntary hold, so somebody is taken to those facilities, maybe by a police officer, or somebody wants to leave and they're not safe. They can be held until a DCR has evaluated them for an ITA investigation. And then peer respites. This is one I am personally very excited about. It's a new concept in our state. The first peer respite, I believe, opened up in January, but they're a home-like setting where you just receive on-site peer support and nothing else but peer support. It's self-directed, so if you want other services or you want other people to come, you have that control, but it's just peers supporting peers. And it's a highly effective model that was developed by a group of people with lived experience in New York who got tired of cycling in and out of the hospital. So they developed a peer respite model, and it's called the Rose House. And it's an incredibly successful operation and shows just the power of peers supporting each other. In our state, stays can be up to 7 days in a 30-day period. And they're meant to be kind of an alternative to a crisis stabilization unit. And then there's withdrawal management. So this is for people who are on an active substance, or need to, want to start treatment and just need a place to kind of get that same stabilization that you get at a crisis stabilization unit, but just for substance uses. So next slide. So those are our crisis facilities. Those are kind of our lower level of care. They're meant to be short stays and help stabilize somebody. But people do need higher levels of care. And so we have our kind of our inpatient tier. These can be our evaluation and treatment centers. They can be freestanding or located in a hospital. That's probably the one you're most familiar with. But I started my career in a freestanding one in Spokane. And it's just a standalone facility. There's longer stays. They're typically 1 to 2 weeks, and a lot of times they're also involuntary stays. There are voluntary stays in ENTs and inpatient, but this is where if you are detained, you would be taken to one of these facilities for an involuntary treatment. They are more intensive. They do provide thorough medication management and discharge planning for the person, as well as skills and stabilization services. Then there's secure withdrawal management, which is basically the withdrawal management version of an ENT, where it is also involuntary and used for people with substance use disorders. And it's about the equivalent stay, give or take, depending on the program. And then for people who really need it, there are longer term beds. So these are the 90 and 100-day beds that you would be transferred to an ENT or a state hospital for a longer stay for ongoing stabilization and support. Next slide. So that's kind of an overview of adult stabilization, the facilities, and where it happens. And I want to reiterate that, kids are not little adults, so I want to hand it over to my partner, Sherry, to explain the youth stabilization side.
Thanks, Matt. My name is Sherry Wiley. I'm the Youth Mobile Crisis Team Administrator, and this heat is playing with my camera, so I'm just going to turn it off while I speak to you. Next slide, please. Okay, so for youth, we know that youth mobile response and stabilization services teams bring the crisis continuum to the youth and family by providing both the initial crisis response and a separate but connected in-home stabilization phase. Just a reminder that WISE teams don't replace mobile response and stabilization teams. Both are 24/7, and WISE teams respond to WISE enrolled youth only. For stabilization, we can stabilize most youth at home, but there does need to be some facility-based care, as Matt said. Washington can benefit from more 23-hour stabilization facilities as a no wrong door alternative to the emergency department. Facility-based stabilization becomes increasingly more and more restrictive, from using the emergency department for behavioral health needs, to adolescent inpatient, to residential treatment, to children's long-term inpatient. Department of Commerce has a notice of funding opportunity for 2 90-day youth residential crisis stabilization programs. Hopefully we'll get one on each side of the Cascades, and these are for youth who may need a longer stabilization period and that may have complex needs. Post-crisis support includes referrals and connection to clinical and community supports through warm handoffs. We want to make sure those families are connected. All facilities and emergency rooms can discharge to youth mobile response and stabilization teams, so parents can feel confident bringing kids home and keeping them safe. Next slide, please. Just to recap the youth presentation, if you weren't here, a reminder that for youth, SAMHSA's best practice is not somewhere to go, but a safe place to be. We don't want to pick them up and take them somewhere. The goal is to intervene before this level of care is necessary. We want the right intervention delivered at the right time, at the right intensity. We want to shift from a risk-aversive medical model that requires evaluation and treatment of youth in hospital settings when certain risk factors exist, to believing we can assess for and create safety for youth, even those with some level of risk in homes and communities. Next slide, please. And back to you, Matt. Thank you.
Thank you, Sherry. So again, to tee up on Jamie's discussion coming up here, these are kind of a list that my team put together, and it's not an exhaustive list of the known kind of issues we have for the crisis stabilization along that entire continuum. So some of this is, well, a lot of it typically is coordination. Our system, behavioral health system, does not always play well with the emergency medical and law enforcement system. So there's sometimes a lot of gaps in communication and coordination and basically just understanding what is even available. Emergency departments often struggle getting a hold of discharge follow-ups. So they have a person in an ED, they don't need to be there, but there's no good plan for them. This is especially acute on the youth side, but you have people sitting there because there's no next step. There's no next stabilization step for them, or it's hard to set up and it's too far out. For our first responders, one of the problems we have heard many times over is, you know, they take somebody to an ED and then they see them on the street a couple hours ago and they don't know why. Maybe, you know, there's a lot of reasons to it. Most common is the person doesn't actually meet ITA criteria and didn't want services. Is that the best route? You know, I don't know. But coordinating and explaining the reason would definitely help with getting people more into stabilization and finding different routes to connect them with services. Maybe taking them instead of an ED to one of those crisis receiving centers would be a better option in the future. And then facility discharges. Like I mentioned before, people coming out of a crisis stabilization unit often need continued stabilization and support as they transition back into their environment. There's pretty good resources coming out of a state hospital, like the peer bridging program and a lot of other discharge supports, but not really on the crisis side. So a lot of times the discharges are to an intake appointment that could be a couple weeks away, or maybe we can get a mobile crisis team back involved with them to continue to support them. But there's still a lot of gaps around that coordination. And then the funding stability. We had a major shift in the way our crisis system operated with integration. And since then, crisis stabilization units have struggled to maintain their funding and maintain their support for many different reasons. A lot of it is really a loss of kind of centralized coordination from the BHASOs and BHOs who oversaw them. But in order for crisis stabilization units to really function, they do have to function that firehouse model where they're available, whether or not they're getting all 16 beds filled, or they're only filling 14 out of 16, or sometimes there are times of the year you don't fill even 5. And then stabilization services funding for mobile rapid crisis teams. This is really more kind of that next bullet point of staffing. There is funding there, they can do this. But it does often require a lot of extra staff time to do those follow-ups, those continued interactions with the person in crisis, and teams don't have that funding right now to add that staff. I know there's provisions coming up in 1134 about doing actuarial analysis, and maybe we can address it there, but we would still have that capacity issue around staffing in general. So these are some of the known kind of problems for crisis stabilization throughout that continuum. But we're interested in hearing your guys' perspective, and if you guys know of any gaps that we are not aware of or haven't thought of. So thank you again for letting us present on the crisis stabilization continuum, and look forward to the conversation.
Sherry and Matt, thank you so much for a really informative presentation. Before I set up our discussion, CRIS committee members, any clarifying questions on what was presented to you today from Matt and Sherry?
I would just add that, so we run residential facilities, we have 4, and so one of the facilities, they, like for example, for adults, voluntary facilities who are stepped down from Western State as an alternative in returning back in the community. We run one here in Washington, in Seattle. I just didn't see a where to fit in your presentation, so I just don't know if that consider that facility, we have patients in there up to 90 days. It might be in your long-term care, or I don't know what part of your presentation those facilities step down will be included, but just to mention that exist.
Yeah, yeah, there's a lot of step down facilities being built, and I think for brevity, we didn't really talk about the step down from long-term hospitalization, but there are new facilities like intensive behavioral health treatment facilities. One of those opened up down here in Olympia. And then there's ESFs, enhanced service facilities. Sorry, it took me a minute to remember that acronym, as well as a lot of other stabilization and step down facilities, but we kind of just cut that out just to make sure the presentation stayed about 15 minutes and we didn't give you guys too much information at once.
Sounds good, thanks.
Linda, I see you unmuted there. Did you have a question for Matt or Sherry?
I just wanted to make a comment that there are a number, probably at 4 or 5 withdrawal management programs that are voluntary that also provide services, crisis services that have the same issues and concerns. So I just wanted to be sure they got included in the consideration.
Thanks for raising that. Let's definitely talk about that when we move into the discussion, Linda. I also see a question in the chat here from Kashi, which is, are 23-hour facilities accessible to youth? They weren't in 5120. Does anyone know the answer to that one? Maybe we'll be covering that later.
Yeah, so 5120 is only for adults, but the 23-hour model has existed as a licensing type for quite some time. And I don't know if there are any 23-hour facilities operating for youth. Sure, Sherry, if you can jump in and tell me if there are, but there is nothing that excludes them from operating a 23-hour facility for youth based on the current rules.
They have a 3 recliner unit being built up in Whatcom County, Matt.
Thank you. I knew there was something, but it wasn't coming to my brain right away.
Thank you for that. And folks, just a reminder, CRIS committee members, if you have a question or a comment, you can click on that reactions button in the lower right side of your Zoom toolbar, and it pops up a window, and then you can click on raise your hand, and I'll call on you in the order in which I see your hand go up. Any other clarifying questions for Sherry and Matt? Darcy.
Hi, sorry, I have maybe a similar question to what Claudia was asking in regard. It seems like in the focus is on people that can be cared for in the shorter term crisis stabilization facilities, as opposed to people who need that higher level of care in the inpatient setting. Is that the kind of conversation they were having? Because I really didn't see a lot of information about some of the challenges related to people that are needing to be in the hospital.
Yeah, my presentation was focusing on that short-term stabilization, crisis stabilization units and the short-term stays in ENTs, not necessarily about the treatment you'd receive in an inpatient unit.
No, I'm sorry, Matt. I mean the challenges with like discharge and capacity, some of those that are related to those kind of stays. I didn't.
Oh, like the fact, like people getting out of the hospital. Yeah, we weren't covering that today. That's another can of worms.
Okay.
Yeah.
Thanks, Darcy. Michelle and then Kimberly.
Well, thanks, Matt. I always appreciate you and your team and hearing and learning from you all. So thanks for the great presentation today. Just a small comment about a couple of pieces about, I know we're talking about someone to come or potentially somewhere to go, but I do think 988 call and text and chat is a crisis stabilization tool. So just for comprehensive, we may want to just capture that on there. And I was also thinking about our crisis response tool, because some people, just speaking back to just like the comments on prevention earlier, that may be the intervention they need, and is all the support right there. Also just thinking about maybe capturing to the original legislation requires the next day follow-up for anybody who contacts 988. And I think that's part of crisis stabilization as well, and thinking about just maybe helping with that planning and resource planning. So just we may want to capture that as well.
Michelle, just to be clear, so on that slide where Matt walked everyone through the ideal crisis stabilization continuum, that first section.
Yeah, I was just thinking both of those could be captured there.
Okay.
Is my suggestion.
Great point. Kimberly.
Hi, everybody, and thanks so much, Matt, for the helpful presentation. Much appreciated. I have a couple of comments. Maybe they're more suggestions, but I hope we have a chance to take up both in our conversation. I very much appreciate the fact that your slide about the ideal continuum was called ideal continuum. I understand that we're looking to make goals here and not describe what's actually happening on the ground, but I wonder if there might be an ideal continuum as well for individuals experiencing crisis that are exhibiting criminal or violent behavior. These folks have rights and have needs as well. And I'm just a little bit concerned that by focusing on the ideal continuum of folks that are not violent and not criminal, we may be excluding a large group of people that surely are in need of our consideration. I know that there's been a lot of talk and debate about True Blood for many years in Washington State. That's not going anywhere quickly. I would love to talk about how competency services and criminal charging fits into an ideal continuum, so we're not leaving a large swath of people unaddressed by our discussion. I also would like to talk about, in the ideal continuum, what is the place for AOT? Assisted outpatient treatment is something that state legislatures have prioritized in recent sessions. There's fundings going to all the BHASOs to promote these AOT programs. I'd like to understand where they fit into our ideal crisis system, with the hope and assumption on my part that they're a really good way to stop that revolving door of crisis stabilization, post-crisis, and then going through the cycle again and again. So a vote here for talking about people that are in the criminal justice system because of crimes that need assistance, and more discussion about AOT. Thanks very much.
Thanks, Kimberly. So two pieces there. One, making that ideal continuum of care more granular, which may mean showing something different for people who are coming in through the criminal justice system because of exhibiting violent or criminal behavior. And then the second is what's the place of AOT Remind me again, assisted outpatient.
Assisted outpatient treatment, yeah.
Thank you, thank you. I need a big acronym reminder on my
We all
wall here in this crisis stabilization continuum. Matt, is there anything you want to speak to there?
Yeah, I would love to hear that. AOT is still fairly new to our state and we're still working on implementing it, but it is designed to be kind of a lower barrier entry where you don't have to go to a hospital first just to get on LRA and support people. I believe it's 18 months. I'm not an expert on it. Unfortunately, my teammate Bridget is, but I would love to have a discussion on how to do that. And there needs to be a discussion, and this is definitely a really complex one, of what do we do for people who do encounter our behavioral health system through the criminal side and not necessarily fall into the true blood class and that type of thing. I think that is a great discussion to have.
Kimberly, I do too. And I think we can talk about how we might fit that into our process. So thanks for raising this. And Betsy noted that LRA is least restrictive alternative for people who are tracking the acronyms.
Thank you. I always forget.
No, that's okay. That's why it takes a village, Matt. Kim M.
Thank you. I just wanted to add to, I think, the comments Kimberly H made, which I appreciated, around the population that is caught up in the criminal legal system. I think what I wanted to add is that the system that we just sort of saw laid out, a lot of our goal is to push all of the great discretion that law enforcement especially has to ensure that a lot of the folks they encounter get moved into the system that we just saw on the screen, right? Because there's so much discretion that law enforcement has to arrest or not arrest across the board and under existing state law. So I think we need to talk about how we off-ramp people who are in the criminal legal system, but the best way to do that is to get to build up this crisis response system in a way that it's can be utilized by law enforcement and anyone else to avoid that initial law enforcement touch, and then to push law enforcement to use that discretion whenever possible not to arrest. I just think we've for so long seen jail as a place to take somebody in addition to the ER, right? That we need to be seeing these other options, crisis stabilization facilities, peer respite places. They need to be open and accessible to people who maybe they were in fact committing a low-level felony offense, but do we really need to take them to jail, or can we utilize this other system instead? We have the discretion to do that.
Thanks, Kim. And I think that's actually a really nice segue to our discussion that I want to set up with us. And I want to link what you just said back to Matt's initial list that he shared that he and his teammates raised about some of the places where we have gaps in the system. One of them related to when law enforcement brings someone in, I think it was to an ED, Matt, you mentioned, and then they see them back out on the street later on without knowing why. So that's one example, but I think we can have a broader discussion shortly about why this ideal continuum is not working out for people in Washington and what the gaps are. And with that, I'm just going to check to see if there are any more questions. And then, I see one comment from Sherry here, and then we'll move into our discussion. I think Sherry.
Yeah, thank you, Jamie. I just wanted to address Kimberly's question about as far as youth, that are contacted by law enforcement. I just want to reiterate that law enforcement are partners in youth crisis, that they're going to contact youth who could be elevated to criminality or booked in juvenile justice. So we do want them to be referring to youth teams rather than transporting them to juvie or to the emergency room. And if a youth does end up in juvenile justice, the mobile response and stabilization services teams, they'll do outreach inside juvenile justice for any youth that are incarcerated, and they work with probation officers and family courts.
And Sherry, to clarify, we're talking about the ideal continuum, but not necessarily how it's always playing out. Am I taking that right?
Right. I mean, the ideal continuum for youth is if they're contacted by law enforcement, they're referred to youth teams and then connected through behavioral health supports, because we know that approximately 3/4 of youth in juvenile justice have a diagnosable behavioral health condition. So we want to interrupt that pipeline to juvie and that pipeline to the emergency room.
Great, thanks so much, Sherry. Any final questions for Sherry and Matt before we move into discussion? Okay, Sherry and Matt, thank you so much for being such a great resource for us, especially in these past 3 meetings where you've been really instrumental in providing us with the information we need to have informed discussions. We are grateful for the effort you've put into providing this information. And now, Chloe, would you mind putting those slides back up on the screen and advancing to the one that says root cause analysis problem statement? I want to set up our discussion. Okay, so we're going to use a tool for our discussion today. But first, I want to remind you of the purpose. The purpose, as we've mentioned a couple times today, is to hear your perspectives based on your professional and/or personal experience on barriers for people to get from that acute crisis or de-escalation phase to stabilization. As Matt described it. So we talked about the ideal continuum, but we want to hear why that's not working out for everybody who needs it. And as I mentioned before, your input will inform strategic planning at Healthcare Authority and also inform future steering committee deliberations about recommendations to address these gaps. So we are going to do this root cause analysis exercise, and some of you may have done this before. It's a systemic process for identifying the root causes of problems, and it's based on the idea that problem solving is about finding a way to prevent problems rather than just putting out fires. So root cause analysis seeks to pinpoint contributing factors, recognizing that there may be multiple contributing factors to a problem. So I'm going to first of all walk through this problem statement that we're going to dive into, and then I'll show you the template that we're going to use to do this exercise. We were originally going to do this in breakouts, but with all the schedule changes today, it made more sense to do this as a large group. So we're going to do this as an all CRIS discussion. The problem statement here is crisis stabilization services offer the community no wrong door access to mental health and substance use care. The goal of these services is to quickly stabilize the person in crisis, avoid hospitalization or incarceration, and help the person transition back into the community. The problem is that in Washington state, not everyone who's experiencing a crisis gets stabilized. In this exercise, please consider a range of crisis stabilization services, including crisis de-escalation, a place-to-go crisis stabilization units, and post-crisis stabilization. Okay, Chloe, can you advance the slide? I'm going to show everybody the template, and it's going to look really small on your screen here. I promise we'll work it out so it's a little bit bigger. The idea here is that we're going to use that problem statement. I'm going to ask you why we have this problem. And Chloe, I don't know if you can zoom in a little bit so we can see the first column.
Jamie, I could also just share the Word document.
Why don't we do that?
Sound good?
Nicola, why don't you put the Word document up and then you can zoom in on that first column, and that'll help people see we put in a couple of straw dogs here to see the discussion. All right, so we're going to use this template today. And again, the problem statement is not everyone who's experiencing a crisis gets stabilized or is able to have the ideal continuum apply to them. And so when we ask the question, why is that happening? One answer that might come up is some people, particularly those who live outside the I-5 corridor, do not have crisis stabilization services in their local area. Well, then we ask the question, why is that? And an answer might be potential providers outside the I-5 corridor have had difficulty accessing adequate funding. Okay, and then we ask the question again, why? So now I'm in the third column here. And two answers might be funding is typically available for capital investments, but does not cover operating costs. And another answer here would be funding sources are complex and can be unpredictable. And as you can see, what we're doing by doing this why exercises, we're building out, shall we get to the root causes of problems. And as we do that, we are starting to get a better sense of where we might be able to intervene to overcome these barriers. And that's the idea of how this root cause analysis works. So what I'd like to do in our exercise today, Nicola has graciously offered to take notes and build out this template for us. What I'd like to do in our exercise today is get your CRIS committee perspectives from your personal and professional experiences, what you've observed and what you've experienced about the reason we have this problem. Why are we unable to get from acute crisis to stabilization for everyone in Washington who's experiencing a behavioral health crisis? And I'm going to ask you all to think about that and then offer some whys, some answers to that question of why. And you may do so either by raising your hand using that reactions button or sending me a chat message. Anna.
I wanted to add to the why for why some people outside the I-5 corridor don't have crisis stabilization. And the why for that is a lack of providers, especially in rural areas. We get a lot of feedback from people east of the mountains where there are no providers anywhere in their area and they have to drive hours on out to find anybody. So that's a huge issue, especially for rural agricultural communities.
And I've heard that one before. That's a great point. Let's do this exercise. Why do you suppose that is true? And Diane, I'm sorry, this is just CRIS committee members speaking, so I apologize that I can't call on you, but thanks so much for being here. CRIS committee members, does anyone have any thoughts to expand on what Anna shared about the why? Or do you have a new answer to the question of why we're running into this challenge? Darcy.
Hi, well, I can just, in terms of in the rural areas in particular for healthcare providers, they're providers of any kind are very hard to recruit for, to get them to live in rural areas. The housing in rural areas, even for people who are making a pretty good income, and is difficult to come by. The list of why it's hard to get healthcare workers in rural areas is very, very long.
Okay, so we have a workforce sourcing issue, and it's related to things like difficulty accessing housing and other issues. Darcy, can you share a few more? Because I think it'd be helpful for us to know this.
Yeah, I mean, in general, not a lot of people want to work in rural areas.
Okay.
Often the pay, particularly if they're coming out of school and they have loans, that might not be, unless they're in an area or they have the kind of loan that could have some, payback, they might not be able to afford to live in the rural area.
Okay, great. So and Nicholas capturing this, so in doing this perfectly, actually. So the answer to our why people outside of the I-5 corridor are having trouble accessing these services is lack of providers, particularly in rural areas. And then Darcy's contributing that it's been difficult to recruit providers in rural areas. And some of the reasons why are difficulty accessing housing. They're not paid as well in rural areas. It may not be as desirable for people who have the training to go live in rural areas. Thank you. And I am seeing a few chats coming in from non-CRIS members, and I apologize, I'm not going to be able to take those. I'm going to have to focus on CRIS member chats, but we are going to record the chats, so we will benefit from your thoughts here. Okay, I see a comment here from Kim M. A new why, not related to the outside I-5 row, so Nicola will go to a new row here, is because law enforcement, this is perfect. Law enforcement are responding to people in crisis and they are being arrested, often for misdemeanor, nuisance, or nonviolent crimes instead of being served by the crisis response system. So this is related to what Kim M was sharing earlier and when we were doing Q&A on the presentation. So Kimberly H., I see your hand up. Before we go to you, I just want to check and see if anyone has an answer to why on what Kim M has contributed, and then I will jump over to Kimberly H.
I
Anyone
think
have
that
any? Oh yeah, Claudia.
Yeah, I would just the same. Then themselves, contribute. Just adding a couple of things. Darcy. It's very difficult sometimes to sustain the provider. So we do have loans. We pay for the loans. We open services in Everson areas who are rural, but it's very difficult to sustain the provider. Once, because sometimes communities are not welcome to outsiders. We had providers who we had recruit, pay, the transfer, give loans to loan repayments for their education. But sometimes providers, especially people of color, do not feel welcome in rural communities, so they decide to move. So it's difficult to sustain or maintain those providers in rural communities.
Claudia, that's an excellent point. Okay, so even when you are able to get some providers to go, if people of color and general people who feel like outsiders feel unwelcome in communities and eventually don't wind up staying.
Mm-hmm.
And Nicola put that perfectly. Okay, I'm going to go to Kimberly and then Chief Harding, but please let me know if you, I think this is working where if you just tell me which why question you're answering, then we can put it in the right spot. Kimberly H.
Thanks. Just to keep the flow going, can I defer to Chief Harding to talk about Kim M's why, and then I'd like to introduce a new topic. Thank you.
That's perfect. We'll come right back to you. Chief Harding.
Okay. Sometimes when we respond, it may be that the people are in crisis, but if they have committed a misdemeanor crime, let's use an example, shoplifting, but they're also in crisis, the caller has the ability to say, I want to press charges. It's not always as simple as discretion on law enforcement's part. So if Home Depot says, yeah, I want this person trespassed from the store, they've shoplifted 5 times this week, and I want them charged. There's a constituency element that the city or the municipality and law enforcement also have to take into consideration.
So this sounds like a constraint on the discretion of the law enforcement officer to offer a part of that crisis response continuum we were talking.
And I mean, systematically, what we'd love to have would be, say, a community court in tandem with that, so that there's a person in crisis, we can use the enforcement element as a tool, but it's to direct them into other services, maybe community court or a community resource center, or if in a perfect world, compelling some kind of inpatient treatment if it's appropriate. So but I just don't think we can make the arrest element always go away based on the idea that we have discretion.
Okay. And I see a little response in here from Kim in the chat, but police can file a report and not arrest or book into jail, even if the victim, and she uses quotes, victim wants to press charges. Chief Harding, any thoughts on that?
There are times that we can, file a booking charge, but not do anything. However, there's also a real element in the community, and that is, victims of crime who are saying, do something.
Okay.
And when they see that, that they're in their mind, a simplistic view, the problem isn't dealt with in a way that also serves them, they become very frustrated. So I'm saying that ideally, it'd be great if we could just use discretion if there was some other alternative available to us. So take them somewhere where they can be connected to services, or remove them from a situation where they may have other options. But walking away from a crime victim, especially community members or service people that provide an economic service in a community, it's a real element. You can't just ignore, in their mind, issues that they're calling us about.
And Chief Harding, just for clarification purposes, when you say that this is a constraint, do you see this as a legal constraint or more of a perceptive or political constraint that you're getting pushback from a person who's been a victim of a crime?
I'd say both, because let's say that I've used discretion and filed charges through investigation 3 times on a subject, an individual, and now I'm confronting them again because they're shoplifting. They haven't appeared in court for arraignment for those first 3 charges, and a judge has issued a warrant. And in that situation, my officers are now looking at an order from a judge, which are very difficult for us to ignore.
Okay, so the point being that there are situations, ones that you encounter where the officer's discretion is limited,
Yeah.
whether it's legally or because you have a citizen who's saying, I want to see something other, I want to see an arrest and a booking here for what I've experienced. Okay, so Nicola, maybe we can, let's move that into the next Y, that one you just highlighted. That's perfect. And then I think, Chief Harding, correct me if I'm wrong, but you also mentioned that a Y on this is public perceptions about what justice looks like. I'm sort of paraphrasing, but that some people in the community are not going to be satisfied and feel like justice has been served if the person's getting mental health intervention. So there's an education piece here too.
Well, I think that's true. If we could somehow provide that victim with assurance that this person is receiving mental health treatment, then they're more likely to be willing to, accept that. But let's, a scenario again, if you're a single mom with 3 kids and depend on your vehicle to go to work, but someone just cut off your catalytic converter and my officer apprehended that person, that mom expects some kind of, in her mind, justice, and probably won't be real happy with, well, I'm just going to give them a warning. I'm not going to charge them, but I'm encouraging them to get some treatment to help them with their issues. That sounds, in this context, in this group, that probably sounds ignorant and callous, but there's a whole nother element of people out there that want something done. So that's why I'm saying it's very important for us to establish what those alternatives are if we're going to say, just use your discretion and don't put these people in the criminal justice system. Does that make sense?
It does, yeah. Okay, I'm going to take a few more. Thank you, Chief Harding. I'm going to take a few more hands and then I'm going to go into the chats. Kimberly, it sounds like you have a new one.
Well, thank you. Although that discussion was so interesting, I want to quickly add to it.
I think we're going to get back to it because I'm seeing a few chats that are going to be related. So go for it.
Oh, good. Yeah, thank you. I just want to bring up a point that I tried to bring up before, and I probably didn't do it in an articulate enough way. I sometimes feel that here on the CRIS, we have a tendency to really privilege individuals with behavioral health issues that are not a safety concern and not engaging in criminal behavior or engaging in low-level criminal behavior. I'd like to suggest as a CRIS member that there are individuals with severe mental illness that engage in truly violent behavior and felonies that deserve our attention and compassion as well. And I sometimes feel like this focus on misdemeanors and this focus on nonviolence and this focus on, people that are at a lower level of acuity is very prejudicial against people that because of their afflictions actually do commit violent crimes. And I would like to see something in this language about the need for systems of care for individuals committing felonies or crimes involving violence. And maybe that's too controversial and difficult for this forum, but it's a population that we don't talk about during these meetings, and I think they deserve our compassion as well. The new category, though, that I wanted to bring up is related to this conversation. I'm so sorry. Go ahead.
Can I pause? I want to make sure we capture what you said, and I do think you were very articulate earlier about needing that distinction. But it also sounds like we can, and it looks like Nicola's getting it down. Take down what you said in a new row, that there is a lack of system of care that's oriented toward people who are in what would be appropriate to say the felony criminal.
Yeah, maybe just to make this simple, Jamie, for the moment, the why that we just talked about referred to misdemeanors. Why restrict it to misdemeanors? Why not a person in crisis has committed a misdemeanor or felony offense? I would just urge us to expand the why in that second column. So we're not simply using our privilege and our influence to assist people that have committed misdemeanors. How can we have a better system of care for someone that's committed a felony crime as well. So
I
that's
see.
the
So that phrase
Right.
in the row above where it says often for misdemeanor and nonviolent
Yep.
crime. I feel
That
like
was my, sorry, this is Kim, that was my intention, Kimberly, for sure, that to include felonies, I was just trying to list several, I think I was saying misdemeanors or nuisance or nonviolent felonies as sort of examples, but absolutely, I think we should be including felonies there. And the RCWs allow, I mean, under 1031-110, it allows for that discretion with any crime. It doesn't.
Yeah, I mean, and then we get into really difficult questions about is police discretion properly used when somebody is engaging in a violent felony? And we can't answer that here, but I at least want to flag it as an important issue for this committee. Thank you for letting me go off on the tangent.
I'm definitely hearing that there are some real complexities with that decision for law enforcement, that decision point for law enforcement about how to handle anything that falls under the auspices of a crime, whether it's a violent crime or a misdemeanor, that is a constraint. And I think you're right that it's probably too complex for us to completely unpack here, but I'm glad we're capturing it because it sounds like we need to do some work on this. But Kimberly, you also had a new one to add.
I have a new why. Thank you, Jamie.
Okay.
And it kind of relates nicely to this conversation because what we have found in our area, and I've heard across the state, is crisis receiving centers being unable to accommodate individuals, and this is not a phrase I made up, out of behavioral control. So maybe more generally, you could say restrictive criteria at crisis receiving centers, because many of these centers will not take individuals that they deem out of behavioral control, people that have a blood alcohol over a certain limit, folks that they deem not medically appropriate, et cetera, et cetera. So restrictive criteria at receiving centers instead of the no wrong door approach is certainly a major reason in my area where we're not using crisis receiving as much as we'd like to. Thank you.
Thank you, Kimberly. Folks who have your hands up, may I ask your permission? I think Darcy has to leave a little bit early. And so would it be all right with you if I took her first and then okay, thanks. Darcy.
Thank you. So I just want a couple of whys to the law enforcement one and maybe to the next one. I do think that, and this again may not be completely popular with the group, that we do have to acknowledge that there is a real tension that law enforcement is required to face when they're not, clinical providers. They're not the people that are able to tell if someone who is accused of committing a crime, and regardless of the if it's a misdemeanor or a felony, if they have a mental illness or not. I think we're asking a lot of law enforcement, and there is attention to the crime victim. And so I do think that this is so complicated that, I don't want us to think that we're going to set up a crisis system that, will alleviate that tension. And I think that will always be part of the why. That makes sense.
It does, Darcy. Yeah. So it sounds like you're saying that because of the inherent need to, or tension of balancing the needs of a person who's a victim and a person who is going through the crisis and has committed the crime, that's not necessarily something that we can expect to resolve, but it is a tension we need to.
Right, or to expect that the law enforcement personnel are going to be able to know in real time, is this the result of a mental illness or is this something else? Because, you can have a mental illness and commit crimes, and it's not always because of your mental illness. So I think we're asking a lot of law enforcement. And I know we're trying to set up a crisis system that alleviates some of that, but that's still going to be there.
So I'm hearing too that because this requires a lot of subjective judgment in the moment, that is a lot to ask of law enforcement, and maybe one of the challenges here. Okay.
And then in regard to the next one about the crisis centers and the criteria for who can be cared for there and who can't. There are actual behavioral health emergencies, and there are limits to what a crisis receiving center, a crisis stabilization center can do. And I don't want us to set up expectations that this idea that they're going to turn no one away means that they can take care of someone no matter how sick they are, or how dysregulated their behavior is, because it's just not. I mean, I will put it out there that I'm talking from the perspective of someone who's worked in the ER, and there are people that will still need to have the care of an emergency room, no matter how perfect our crisis system is.
Thank you, Darcy. That's helpful on the restrictive criteria at crisis receiving centers, adding some nuance there. And I do kind of want to reflect back on what Kimberly was saying about a particular group of people, but it sounds like this can be expansive here, that that we don't always have an ideal continuum to support the particular needs or intervene with, for example, someone who's committed a felony as part of their crisis. And I hear Darcy saying that some of these crisis receiving centers don't have the tools or the resources to deal with some of the particular ways that a person is experiencing a crisis. I'm going to pause for a moment. I see a lot of hands, so this is a really robust discussion, which I appreciate so much. I do have a lot of chats that I need to catch up on here, so I'm going to pause for a moment and then I will come to you, Bipasha. All right. Let's see here. All right. I hear from Kashi back to why is law enforcement responding in the first place? So that would be our row. I'm going through a couple of screens. So I think maybe Nick, in the second column on the row on law enforcement, we can add potentially a new cell here, which is law enforcement. This is a little bit of a circular reference, but I think it's a really important point. There's not enough mobile crisis resources, and that's why law enforcement is responding in the first place. So Nicola, that would be, yeah, there you go, perfect. And then we can always fix all the formatting later on. And then another one is there's not enough training for law enforcement in behavioral health crises. And I remember Chief Harding talking about that, I think the last meeting, that that there's training, but we need to collaborate more on making sure we have the right training. So I see a comment here. I'll let Nicola catch up and then we'll go up to the.
Did I capture that, Jamie? Just the lack
I
of
think maybe changing it to lack to maybe it's like
not enough
or need more specific training.
Yeah.
Okay, and then if you want to go up to the row where we're talking about workforce, which was the first row. Dylan shares, I think recruitment for rural areas also speaks to societal trends of urbanization. Access to other services and quality of life amenities are just harder to get in rural areas. Not many want that type of life. And I think this is even more prevalent for current generation graduates. So I think this echoes some of the what we heard earlier, I think from Claudia, about people don't, and Anna said this too, I think that people don't always want to live in rural areas.
And I had that.
Yeah, you got that. You got that well.
Yeah.
All right, so let's go down now. We've got one from Carrie Waterland. Going back to the one about why police are responding. So it's a new cell under the two that you just added. Is that there are more police per capita than behavioral health and crisis providers. And they are paid for services on a 24/7 basis. I think the firehouse model that Matt was referring to in his presentation, as opposed to a case-by-case basis. So, Carrie, I take your comment to mean that police are responding because in some cases there's just more of them, and there's more, they're more available to come when there is a crisis. And some of,
I think that's a question. I don't know, right? And so I think that might be something that we would want to look at as well, right? Is how is all of this resourced and how is all of it paid for? And if we really want to compare kind of adequacy of the availability of services, we maybe should look at apples and apples, right? So if it's if they're funded the same way, and the numbers are the same way, then that gives us a true ability to have a conversation of kind of what, you know, what a response really could and should look like from that kind of dream point of view. Because I think there's room for there's absolutely room for both, right? We just need to also, I think, compare the way that they're funded and rolled out so that we're really all having the same conversation.
that is a great point, and it looks like Nicola's framing the point here that way. So we should ask ourselves the question about how we're staffing police, how we're funding it, and that there's a role for both, I'm hearing, but we need to know if some of these differences in how we fund and staff these roles are actually contributing to some of these problems. Nicola, you're a hero. Thank you so much for taking down the notes.
Well, thank you all.
While you're doing that, I'm going to share something that doesn't go in a box, but I think is important for folks to hear. Anna shared that she has personal experience with what Claudia said about people of color not feeling welcome in rural communities. She mentions that when we were looking to purchase a house, my children and I experienced racism in a rural community that they had been interested in moving to. Anna, thank you for sharing that. I don't imagine that's an easy thing to share. I appreciate it. I see, Kim, I might need some help with this one. Kim M, you mentioned police have discretion to say we will take this person to crisis stab and file a report. Oh, I'm sorry. I'm just misunderstanding the abbreviation. Police will have discretion to say we will take this person to crisis stabilization and file a report and not arrest and book. So I think, yeah, I think we've covered that one. I think there's some real complexities here that I'm hearing from Chief Harding and Kim M and Kimberly and others about how far that discretion goes and how you balance the person in crisis and the person who's experienced or is the victim. Puck, I might need some help with this one. I see here, since when do they have a record? And I apologize. I think this was probably responding to an earlier comment, but I'm not exactly sure which one. So if you want to send me a chat with some clarification, that would be great.
Oh, that's fine. It was just that suddenly the person with the mental health crisis was having more and more complications.
I see. Thank you for that. Okay, another one from Anna. We're almost through the chats here, and then I'll come to the folks who've been patiently waiting with their hands up. I'd like to respond to the caller has discretion to request the person is charged. This is from Anna. This is an issue because what if the caller is racist and is more likely to request a person of color is charged over a white person? So I would say, Nicola, let's put this in the cell where we're talking about the complexities of balancing the needs, I'll say needs here, there may be a better word, but the needs of the person in crisis and the needs of the victim, that racism can play a big role in what action is taken. And then
I think, is that part of refining this why statement? The responsibility to the victim and the community.
Yeah, yes, that's right. I think that's going back to also what Darcy was sharing about that trickiness. And then Marie, I might need some help with yours. It says add lack of training and compensation. Is that for the workforce one that you wanted to add that one to? If you want to just send me a chat, that's fine. I think that's the workforce one. All right, folks with hands up, really appreciate your patience. Thank you so much. Let's go with Bipasha. And you are on mute, Bipasha.
Well, of course I am. I just wanted to say address a few different things since so much has been said. Kim Hendrickson brought up the issue of people in crisis might be behaving in a way that, is physically manifesting through their body. I just want to clarify, the whole point of being in crisis is all of us by definition do not behave the way we would under not crisis behave in crisis. That needs to be considered in the definition of crisis. If you want someone to behave calm, they're not in crisis right in that moment. So it's not unusual to have people physically flailing. That is not a sign of danger to anybody. I worry that those kind of expressions get read as, oh, is that person dangerous? That being said, people can be physically aggressive. Let me put it that way. I'm using aggressive very specifically, separating it from dangerous. Okay, so I just want to be clear. I know that when we went to Arizona, they said that the behavioral health staff, some of them were trained to physically de-escalate people. And I think we often turn to the police for physical de-escalation. I think we need to at some point talk about how behavioral health providers might also need to be trained on physical de-escalation, again, within the range of it being aggressive, but not dangerous. I don't know how else to say it, but we did hear about that in Arizona. I want to come back to rural. One thing that I'm absolutely have very little experience in the rural area, but I've been listening to a lot of meetings where people speak up. Technology access is a huge issue in rural areas. We assume living in urban centers that we have access to stable internet. A lot of people in rural areas don't have that. So that's something specifically for rural. There were a couple other things that came up for rural when I was thinking about it in listening to a lot of conversations I've attended. One is stigma. And I've heard a lot of people in rural areas say they live in very small communities, people know each other, and there's some stigma around getting help. But I think whenever I listen to stigma, I think of immigrant communities in urban areas. They have stigma is a lot more common across communities than we realize. So for me, stigma is a bucket that covers rural, but also communities in urban areas. For example, immigrants who are bringing some of maybe their country of origin stigma when they come to the US. So that's important to address. The other thing I've been talking about a lot is that there is no easy place to access information on what to do in a crisis. So we're thinking of building a system. We don't even have a centralized database on what exists right now. I work on a crisis line, and I talk to my supervisors who are professional mental health professionals, and we don't have a centralized database on how to plug people into what if something already exists. I think this is doable for us to start building a database on what is already available right now. And my last point will be a little bit more esoteric, but I want to qualify it by saying, this is not an absolving on experiences that many people have with law enforcement. I have a lot of respect for Chief Harding and Kim, and I think I really think they probably are very much in the know more than I am of certain police officers that they might themselves be a little skeptical of. I won't go there now. That's important. We need to resolve that issue in this country, but I do want to say that the police system is a reflection of us as a society. We can't separate that from us. It's what we want as a society. And I speak as a person of color who's an immigrant, and I can tell you there are enough people of color who will call the police. This dichotomy between people of color don't call the police it's not true. You cannot put everybody in one group. So I want people of color also to take responsibility for the fact that we might be calling the police when we maybe should consider that the person's having a behavioral health crisis, which then leads me to a central issue. A lot of this is education. We have a society based on black and white and punishment and reward. And we really need to do a good job of educating people on what is behavioral health. How does it manifest? Why is it important to get care for it? Why is it important to ask for care for your community members when you're observing them go through it, rather than saying, I want them punished? And I think that is on all of us as individuals. It doesn't lie with any one group in our society. I strongly feel that. And I will keep quiet.
Pasha, thank you so much. There was a lot there, so I want to make sure we captured all that. And Nicola is doing a heroic job taking this down. So,
Jamie, could I just pop in here?
Oh, please.
I just want, I pinged Nicola, but I just want to say that it sounds like stigma might be another category.
Yeah, she actually put that on a new.
Oh, she got it. Okay, I'm sorry. I was busy trying to flag that that's a.
Thanks for helping us catch that. Yes.
Thank you.
So starting with a really important point about the way a behavioral health crisis manifests in a lot of people is with physical demonstration, which can appear violent, particularly for someone who I apologize. I just saw chat popped up that distracted me, but I want to echo it. I want to share it because it's from HCA, and they said, since I can only chat to you, Vipasha, please never be quiet. That's what Luke Wagner said from HCA. So clearly people value your perspective. Thanks for sharing that. But you said because people in crisis can be manifesting their behavior in a physical way that may even be violent or appear dangerous to people. That is a reason why police are often called, and a reason, it's two reasons actually. It's why police are often called and why we need some education on what a mental health crisis is and how it might manifest. I heard you talking about stigma, but you wanted to broaden that because certainly people experience stigma against getting help for behavioral health crisis in rural areas, but you're observing that this runs the gamut. It goes across a lot of different communities, which is I think what Betsy suggested and why Nicola put it in a new row. And then another really important piece that you mentioned was that that policing and how police engage with people in mental health crises are really a reflection of our society and how we want and see things. And so you mentioned that a lack of education on what behavioral health and what crisis looks like is a contributor to this why as well. Thank you, Vipasha. I see a number of hands up. So, and then I'd like to do a time check because I see Vicki Lowe is here, and I want to maybe we might take a little pause and hear her presentation on tribal-centric crisis stabilization. Then we can come back to our conversation. Jessica.
Thank you. I wanted to comment originally on the piece that Kim had mentioned about the restrictive admit kind of criteria around crisis stabilization facilities. And I think that an important piece of that why is just resources, right? There are staffing and resource requirements around the type of complexity, medical, behavioral, otherwise, for clients. What is that client's need at that time? If they are requiring a separate staff person to sit with them, or they are requiring a separate space where they can be kind of away from additional stimulation and away from other people. If they are maybe they have been the victim of something and they cannot be in a shared room with another person because it doesn't feel safe. Or maybe they have medical complexity, or not even medical complexity, but just care needs. All of those things require additional staffing and additional resources, and that costs additional money. And so if we want to create a crisis stabilization system, facilities and system that can manage those diverse and complex needs, then we just have to build it, because the expectation that we're going to create something where no one gets turned away, but we don't build in an understanding that some people are going to need more for their safety and for others' safety, we just have to have that kind of upfront. I mean, medical and behavioral complexity and additional needs is something that we face as barriers for involuntary treatment and for voluntary treatment. There are evaluation treatment facilities and psych facilities now that cannot take certain levels of complexity. So I think just being aware that really it comes back to staffing and it comes back to resources. Someone whose blood alcohol level is above a certain level, if they go into withdrawal, that is a medically unsafe situation. So it's not simply a matter of they won't take this person because they don't want to deal with it. It's, is it safe for them to take this person? But we can build those resources in if we know to expect them. So that was that was what I had originally raised my hand. I want to comment on the conversation about the difference between behaviors that appear aggressive and whether or not they're dangerous. And I don't have a right answer. And I don't want to have a battle of perspectives, but I will say that as someone who has done crisis outreach in various forms for many years and who has been assaulted by clients who did not mean to hurt me. They were experiencing their own thing. They were experiencing their own crisis. And it's not passing judgment on someone to say that their behavior in that moment is dangerous, either to themselves and or to other people. And I think that it's simply a fact of the situation that there are safety concerns in that particular situation. And we have to figure out a way to manage those safety concerns for that individual and for the people who are going to work with them and assist them, and for their family, and for other people in their home, and for the other people around them. Whether or not that's a police response is, I think, part of a larger conversation. But I want to caution dismissing that something appears dangerous, but it's not, because it's mental health. It can be both. I also have concerns about discussion about training behavioral health workers to do physical de-escalation. If you are not in a facility, if you are in someone's home, you are a private citizen, you are another person in their home, and setting up an expectation where I, as a crisis worker or a DCR who is in someone's home doing an assessment, that I'm going to engage in a physical intervention with them is very concerning to me. Because then we're setting up a whole other situation with some, there are some elements of risk in that. So I don't know what the right answer is. I'm not saying that the right answer is police every time, or not police, but those are the pieces based on my experience doing crisis work that kind of flagged for me.
Thank you so much, Jessica. I want to pause and make a point here. Because Jessica, you said a battle of perspectives. And in fact, I really, this CRIS would not be very effective if everyone agreed on everything or had the same experience or the same perspective. So I am very grateful, Jessica, for you sharing your perspective on this, Bipasha, for you sharing yours, and others today. And I'm actually grateful that we are coming to this from different places, different experiences, and different perspectives. I've also heard a lot of you acknowledge that there may not be a right answer, or the right answer is elusive. So I think we're doing the right things here, having this conversation, and I'm glad that I'm glad that you're raising these. I also see a note here from Bipasha wanting to clarify that she was referring to people who did physical de-escalation, not in the field. This might be one too, where, because I understand from what Bipasha shared that Arizona has done some of this, it's not a thing we have to invent, but that we can investigate and learn more about, being mindful of some of the considerations that Jessica read about the safety and considerations and limitations of a private health provider in the home that may be different from someone in law enforcement. I'll add here, I see a note from Claudia that she agrees with Jessica's comments and share her perspective as the provider of residential care. Jessica, thanks so much. I have a couple more hands, and then I'm going to want to pause and see, we'll talk about what to do next so we can continue our conversation, but also be respectful of some of our presenters' time and hear from them. Chief Harding.
One of the things I just want to make sure we don't lose track of, and I've made this point a few times, is that we cannot determine the intent of the person picking up the phone. And some people, there are a group of people who will dial 911 because they have already determined the outcome that they want to see. So law enforcement will be involved in behavioral health calls sometimes because the person calling doesn't want behavioral health solutions. They want law enforcement to come, in their mind, fix a problem. So that's why we have to keep abreast of training. We have to be not forgotten in this system, but provided more ability to train and recognize what we're actually dealing with. So when it's not a criminal incident, we make the right decision, we refer them to the right place, or to another point that someone made, and I think it's under the second Y. There was a comment that we have discretion to take them to stabilization services. That would be great if they exist. But after 5 o'clock on Friday, Saturday, Sunday nights, where are they? And how do we get people to them? So all I'm saying is we need more of those. We need more training to recognize the actual need and the primary need. And then we can collaborate those services together so that we get them to the right spot. Or we call a mobile response team when someone's tried to use us for a job that we aren't intended to do. But we got to be part of the system to be able to work those solutions.
So Chief Harding, I feel here a few points that I want to make sure we capture. So, and yes, you have mentioned them. I think they're up here too, but the first one that you mentioned and you've mentioned before is when the person who calls 911 already has a sense of what outcome they want, that might be where you get very constrained on how much discretion you have. And so I heard you mention something about education and community education.
Yeah, I don't know that it so much is an impact on our discretion, but it's the intent of the caller. Sometimes the caller will dial 911 knowing full well there's a 988 option, but they don't want 988. They want us to come up and fix the problem in their mind. Remove that person from the area.
Okay, so that's when it triggers a different response system.
Correct. Maybe there's no
levels
crime
of training
committed.
and different orientation.
Yeah.
Okay, excellent. And then you reiterated a point that I think is important to capture. And I think Nicholas got it up here about not just needing training on what the appropriate response is for law enforcement, since there are going to continue to be cases where 911 is called rather than 988. And second, that there is a place to go or someone to come, because in some communities, in a lot of communities, those resources don't yet exist, or they don't exist after 5 o'clock.
Yeah, it says note that police have discretion to take people to behavioral health crisis support. That's the specific comment that's under the Y. There you go.
If they're actually available.
If it's available.
Yeah. Okay, great. All right. Kashi, I'll take you in just a sec. There's a couple of chats here related to what Chief Harding just said. There are communities that have been historically, this is from Anna, there are communities that have been historically traumatized by the police In many cases, a police response will only escalate the situation. This needs to be addressed. Law enforcement needs to be the absolute last response, no matter what the caller wants. So I think this is relating to Chief Harding's point about how sometimes people call 911, even if they know 988 exists, and that triggers an entirely different system. And then Michelle says, in response to Chief Harding, there is work we have ahead between 988 and 911 to trust build and consider criterion situations where 911 may hand calls off to 988 instead of responding. So that's exciting news. Kashi.
Thank you. I think one of the things I'm having a hard time with, and so this is maybe a point of like process consideration, is the more specific the first why can be, the easier it is to articulate the subsequent whys. And so that statement about law enforcement actually has 2 or 3 different components. And I think that's what's contributing to at least my own confusion of the conflation of some of these issues, right? If the first presenting concern or why is law enforcement responds to situations that of behavioral health crises unnecessarily, or the whys there are because there aren't mobile crisis resources, because the crisis centers close at 5, because, you know, there's a stigma about resourcing behavioral health instead of resourcing law enforcement. And if the first, you know, why is there are unnecessary arrests, or arrests are made inappropriately, there are subsequent whys. And we're trying to connect all of these whys to one multifaceted statement, and I'm having a really hard time tracking it. And so, Nicola, I would hate to be the person typing this as I hear what's coming out of my mouth. So please don't try to do this in the moment. But my request perhaps, or a consideration, is when these get sent out as notes, if they could be reconfigured into separate whys, I think that would be really helpful to help us in the spirit of trying to get to a root cause. It would help us to be more specific at the beginning so that we could get to root causes that have solutions at the end. And I have 2 other quick things I just wanted to mention, going all the way back to why can't people get crisis stabilization? For youth, that's because there are no places to go. There are no current crisis stabilization units or beds. I'm happy to be publicly corrected if I am wrong, but I am not aware of a single crisis stabilization unit for youth. And then there's probably a series of why that I don't even have all of the answers to. And the last why I wanted to represent was just there's a lack of preventative care and supports for people in our system that prevent people from entering crisis in the first place. And that may not be appropriate for this RCA type exercise, but the social determinants of health seem worth mentioning here, that if you have housing or can put food on your table and can access the healthcare and medical care and mental health care that you need, and you have a community and a place where you feel seen and loved and heard, that makes a big difference in your life and whether or not you experience a crisis. And that doesn't mean they're all avoidable, but it means that we don't have a lot of preventative resources in our system. Our system isn't set up to fund or incentivize that. So I just thought that was worth noting in the conversation. Thanks.
Kashi, thanks so much. So first off, to answer your question, yes, Nicola and I plan to synthesize and organize all of this and try to align it as best we can with how we recollect the discussion. That said, we will be counting on all of you CRIS committee members when you get the notes back to take a look and make sure we did organize it the way that you see that it should be and that it is intended. This is definitely, particularly doing this in a large group, a bit of a top of the funnel exercise, but I appreciate all the energy that everyone's bringing to this conversation. So thank you for raising that. And then second, it sounds like a why here is actually related to both Joan's opening remarks and Senator Dingera's remarks about prevention, and that we don't have enough preventative services to limit the number of people who need to access this system in the first place. And in fact, people that are not able to get to that crisis stabilization piece, sounds like they suffer on both ends. They don't have the preventative services in the first place, and they don't have all of that ideal continuum available to them. Did I catch that right? Thanks, Kashi. I just want to mention that I got a nice note from Vicky Lowe, who's here. She said she's available till 3, and so we can continue. I think I don't want to interrupt the discussion. We can continue going. I was planning on giving you all a break, but I'm sensing that people still really want to stay in this. So if you're feeling like you could really use a break, please send me a chat and I'll call one. Otherwise, I'm going to sort of read the room, which is not as easy on Zoom as it was in real life, and keep us going here because there's a lot of energy around this discussion. Dylan.
Hey, thank you. And I just want to show appreciation for Kashi and being able to just talk about the social determinants of health here and looking at those upstream supports that we would really like to see here. But this also just like we're talking about 988 and a more, I guess, a specific component of maybe eventually getting there. How deep into this root cause analysis are we trying to get? If we're looking, are we talking about trying to undo generations of stuff? Are we trying to get to more of a utopia of societies here? But there is like sort of that big picture where I think I would love to be able to get to eventually, but we also have our charge here as of right now of what tools and resources and funding do we have to try to take action and move closer to that. So my question is, how deep into this are we going into? Are we going to solve racism? Are we going to solve all sorts of stuff and colonization? And yeah, that's just why I'm wondering here.
It's a fair question, Dylan, and to your point, we do need to stay focused. That said, when I've done these root cause analyses on a number of topics, most recently when I was facilitating the universal healthcare work group, and we did some work on this. And the reality is that there are conditions that, to your point, are much bigger and not really within our control. And it's good to get those down too, because then what we can do is identify the places where we have some influence or we can make recommendations, and then other places where we know that exists and we have to mitigate or work around it, but we're not necessarily going to solve it. So I hope that answers your question, but if you have a contributor here based on the answer to that, please jump in.
Jamie.
Oh, sorry.
I'm sorry, Dylan. I want to reinforce Jamie's message that I think looking at the continuum of services, which includes prevention and upstream opportunities, is important for this work. And as we're making recommendations for both this interim report and the final report, we're going to want to think about our goal ultimately in preventing crisis. And so I think the lack of prevention services and social determinants is definitely a factor that we should consider.
Right. And then and not sort of off topic, but I did want to circle back to Ron's point about like, well, where do we send people, and then the determination of, we are already talking about how first responders are not trained in mental health here. I'm wondering how is that determination met, or maybe the use of consultation for making some of the determinations in the mental health field. I rarely am making a decision completely on my own. If there are just times where just being able to call, like talk to a colleague or a supervisor I have with a challenging case, it makes all the difference in the world to me in being able to talk through again, once we're able to kind of get to a point that's stable enough that we could step away or just even call someone in for support. So it's something.
Dylan, I'd love to talk to you about co-response. That's the best advertisement for co-response that I've ever heard. Thank you for bringing that up.
So Dylan, I just want to make sure I'm tracking. If we're talking about the why here, your point is that that having colleagues and thought partners in this process are really important, and team members, and in some places people who are intervening don't have that. Is that?
Yeah. So I think if we're looking at second column here, where we're talking about discretion to the police for when to tag in behavioral health, but what about just being able to tag in, like, it doesn't have to be discretion here, or why not always bring that in?
Okay, so right now, the way the system works, there's not really that intersection or partnership in some places. And you're saying that rather than the answer being the police having discretion to make that choice, that it's a discussion they have with their behavioral health partners.
Yeah, behavioral health, or just looking at, like, let's say someone steals a TV, they need that money to do something else. Why would I mean, again, we could keep going down the line here
Sure.
of but yeah, I think most of the time there is a behavioral health component, or a personal need that a crime or a behavior is trying to serve.
Well, and I can definitely see why Kimberly's ears pricked up there, so. Thanks for making that point. It looks like Nicholas getting that in there. And when Kashi, when we go back through and synthesize all of this, we'll also do reframing to have it fit with the why piece so that it makes intuitive sense when you're all reading it and remembering what we said.
Jamie, if I may, just Dylan's theme of like cross-agency and cross-entity collaboration. That's something that was brought up at the beginning of this conversation in a different context. Chief Harding has talked about the importance of understanding how police fit into the larger system. I mean, the more we can drive this conversation to how do we get beyond our, our silos and work more collaboratively together. Yes, Dylan, agreed. I'm very vested in the co-response movement because that's a multidisciplinary approach to a 911 call, but that same logic applies to so many other situations in the crisis system where the systems are simply not talking to each other. Thanks for letting me butt in. Sorry about that.
Kimberly, it sounds like the why here might be next to that cell that Nicola just put in. That's that we, if I'm using your language, we continue to stay in silos and need to be oriented more, or can look to being more oriented toward cross-system and cross-agency partnerships.
Beautiful. Cross-systems collaboration and building programs, even within their agency that calls on the expertise from different professionals. So again, to go back to co-response, the ideas of incorporating peers in a fire team, right? The idea of having a mobile crisis team that works very closely with a police department. Just understanding how all of these pieces have to fit together in order to be effective, and that we can learn from the specialized expertise of each other if we're willing to get beyond conventional programs and silos and start to work together.
Thank you, Kimberly.
Thanks so
I'm
much.
going to pause here and go into the comments because there's a few in here. One more from Kimberly: a general lack of crisis services, lack of mobile crisis teams, lack of crisis receiving centers, lack of peer respite, and lack of co-response teams. And I think that'll be a first column one, but it also fits with a lot of the ones we've talked about. Let's see. Just a note here from Michelle Roberts. Thanks to Kashi for noting the social determinants of health and social economic factors and structural racism too is an underlying factor.
I'm sorry, can you repeat that, please, Jamie? Too fast.
I'll say it again. Thanks to Kashi, and I'll use my outdoor voice. Thanks to Kashi for noting the social determinants of health and social economic factors and structural racism too as an underlying factor. I have to remember our ASL interpreters and not use my speed talking. Let's see. And then one from Bipasha, specific suggestions to some big societal problems. I'll let Nicola catch up and then I'll read these.
Okay, I think I'm there, Jamie.
Okay.
Yeah.
Education on behavioral health can and needs to start. The state can play a central role in developing these educational pieces that is easy for people to access and come up on TV too. I don't know who develops that, but it can make a difference in deeper societal issues such as stigma. And then number two, start by building a database on what already exists around behavioral health in Washington state, public and private for low income and high income people, and add new things that come up as they do. Make that database easy to use and accessible to the public so they can check out their options before they even need to call 988 and 911. And database, I'm recalling what Bipasha said in her earlier comment that I think I forgot to highlight when I summarized. She mentioned this database, but behavioral health services that start at the very far end of prevention and go all the way through the continuum. And then a note from Joan Miller, there's lots of stuff in Rep. Orwell's bill this year about training and building regional collaboratives among first responders and behavioral health providers. So that kind of echoes the point that Kimberly was making. All right. I am not seeing hands up, so this might be a good time to pause and hear from Vicki Lowe with the American Indian Health Commission, who joined us today to share some information with us about tribal-centric crisis stabilization services. So why don't we do that, catch our breath, and then I'll check back in with you and see if there's what we want to do next in terms of continuing the conversation, taking a break, or moving into our legislative wrap up. Vicki, thank you so much for being here. And Chloe, maybe you can share the screen with Vicki's slides.
Okay, I was just going to ask if I was sharing. Thank you. I squatchy Vicki Lowe Sinsna Statitlam Nisklayan Sinsna Nislak. My name is Vicki Lowe. I'm Jamestown Sklallam and Bella Hookulla First Nations from Canada. I'm here today as the Executive Director of the American Indian Health Commission, working on behalf of the tribes, the urban Indian health programs, and Indian healthcare providers here in Washington State. I'm going to tell you about some work that we have going on. We've been working on for about 6 years, but it coincides with a place to go, or somewhere to go. And so we've been working to develop some tribal evaluation and treatment facilities in Washington State, because there are no tribally operated ENTs or secure withdrawal management facilities, with the caveat that there will be some soon. So this, oh, can you go to the next slide? I forgot they weren't on my screen. So I'm not going to read all this, but there's a long history of why we need to improve the access for American Indians, Alaska Natives in Washington State. And in 2013, there was a report to the legislature done, a group of tribal leaders and DSHS and Healthcare Authority, the American Indian Health Commission, and the Northwest Portland Area Indian Health Board came together and did this report, and it had quite a few recommendations. There's a link at the bottom of the slide that gets you to the report if you're interested in reading it. Next slide. And so one of the recommendations was to stand up a tribally operated evaluation and treatment facility. So we implemented a work group. It took a little time. The funding started in July 2017, but we really didn't get started until November. And out of that, we created 5 subcommittees to help support the work. There was one on clinical and cultural models, one on the facilities and siting where it would go, operations, you know, how much it would cost and how much funding we could have coming in for reimbursements. Legislative work, we knew that there needed to be some changes in the legislature in order for this to happen. And then governance, who would govern the facility? Would it be an individual tribe? Would it be tribes in a region? Would it be a statewide effort? Next slide. And so the first work group about culturally appropriate practices, we know that when facilities are operated by non-tribal entities, that it's a lot more difficult to get appropriate, culturally appropriate services. So we knew that if we had a facility, that we would need to be developing the culturally appropriate practices and working with each of the tribes to understand what that would be. And so this work group worked on some of those ideas. Next slide. We talked about different ways to fund the facilities. You know, tribes aren't funded to build facilities, so there's Department of Commerce and all these other places that we looked at, and we knew that we would need to probably put together several different funding options in order to make it work. Next slide. And then we had a huge conversation around, does it need to just be an evaluation and treatment facility? Do we need secure detox? Could we actually do both a facility that had so many beds for secure detox and so many beds for ENT? And we knew that secure detox was a big issue that we needed to incorporate it into this work. Next slide. And then here's what we looked at for the staffing models, and really being thoughtful, thinking about if we had a combination facility, you know, how would that look? You'd have to have, you know, 2 different sets of staffing. Next slide. And then something to get us going right now, tribes could actually contract beds from current providers, and that way they could bring in more federal funds into the state to help pay for the services. Next slide. And so then COVID happened, and so everything got put on hold, unfortunately, because all the tribal leaders, tribal health people were really focused on protecting their communities during the pandemic. So if you go to the next slide, we're coming back around to this work. But we did accomplish some things despite the pandemic. We passed the Indian Behavioral Health Act in 2020 that establishes a process to appoint tribal designated crisis responders so that they would work for the tribe and do the work of the DCR. And then also to have notification to our Indian healthcare providers and tribes when one of our tribal members is involved in an involuntary treatment process, whether they're detained or not, just so that the tribe can be more involved. Next slide. We implemented a coordination hub that is in the process of being renamed. It was called the Washington Indian Behavioral Health Hub, and going forward it will be the Native Resource Hub, and that helps support Native people in crisis, their families and their providers in finding beds. Then when we were working on that, we kind of got drawn into the 988 work, and that's where we got the Native and Strong line. So if you call 988, you have an option if you're a Native American to press 4 and speak to a Native American counselor. We've been working with Jessica Shook to train the non-tribal designated crisis responders about how to work better with our American Indian Alaska Native patients and our tribal governments. We have helped review the Washington State Designated Crisis Responder protocols to include how to coordinate better with tribes and Indian healthcare providers. And then as part of the Indian Behavioral Health Act, tribal governments can also petition for involuntary treatment under Joel's Law. And we've actually had one tribe successfully do that. Next slide. And so what we have left to do is figure out with these evaluation and treatment facilities, do we want to have a statewide one? Do we need a governing board? Are we going to help support individual tribes or tribes in the region doing these things? How do the crisis stabilization facilities fit into the plan? And there are a few tribes that are actually very interested in this model because it's a lot less institutional, less invasive, and we think less traumatizing to our people. And so looking at the need for more statewide facilities, and then following through on, is there a way to contract beds with hospitals and still provide those culturally appropriate services? Next slide. And then we still need to update all of the information I told you because it's from 2019 and 2020. We need a clearly laid out licensing and approval process. That's one thing that we come into issues with building facilities in the state where we're going to bill Medicaid and possibly private insurances, that we get this nexus of federal and state laws and certification and licensing processes. So we need to get that figured out. We need to really update the costs for building or remodeling and operational costs, and understand if the reimbursement costs and court costs have changed over time. Next slide. And so tomorrow we're meeting our work group that works on this and to discuss what we'll be doing going forward. But I know as of now, there are 2 tribes that are opening their own facilities, or they're getting funding and opening. One is a ENT and the others is secure withdrawal management. So we'll at least have 2 tribally operated facilities in Washington state. And we're looking forward to working with the tribes and helping support what else that they can bring to the table. So thank you.
Vicki, thank you so much. That was really informative, and it was so interesting how so many of the things you talked about are actually related to some of the needs or the gaps we were seeing in our conversation today. It's a very apropos. Anyone have any questions for Vicki about what she shared today? Hopefully you saw the link to her slides in the chat that Brittany put in, but we'll have them posted on the HCA CRIS committee website so that you can go back and read more closely and follow the link she shared. Vicki, thanks so much for being with us, and thank you for your flexibility on timing. It was very, very appreciated. And just also, Vicki's been our go-to when we've said what ways can we educate the CRIS on tribal centric behavioral health, and Vicki's been just such a great resource and supporter in pointing us in the direction of where we can provide more information to the CRIS. So thank you for that, Vicki. Okay, I want to check in with folks. It's 2:15. I have one public comment that the person's actually asked that it be read for them. So I'm going to read that. And then we have a presentation from Senator Dhingra on legislative wrap up related to the summary that you saw in your newsletter. But I actually have a couple of, I went back and checked the chat to make sure I hadn't missed any comments, and I have a couple of comments to share on our previous discussion. But I also want to check in with all of you to see if you have anything else I'm seeing a desire for a break. Okay, how about we do this? How about we take, since we only have 45 minutes left in our meeting, how about we take a 5-minute break, and then we'll come back on screen. I'll read the last comments in our discussion, and then we'll move into our legislative wrap up. Sound good? Okay, so everybody, if you could be back on screen, it's 2:17 right now. Let's be back on screen. Let's be back on screen at 2:25. That gives you a little bonus time, and then we'll go into the legislative wrap up. Thanks, everyone. Okay. We can see some cameras go back on. All right, I see folks coming back on. Quickly, I have a couple of comments in the chat that I want to circle back on. I didn't read them before. The first, Nicola, there was one from Marie that I clarified with her. We can add this. You don't have to put it back up on the screen, but I just want to make sure it gets on there, which is to add lack of training and low compensation to the workforce row that we were developing as a why. And then I just want to share a note from Bipasha. This goes back to Jessica Shook's comment about the experience as a provider. Bipasha says, I hear Jessica and respect her point of view. Have friends who are designated crisis responders, and I respect their safety because both clients both clients and responders are human and need to be respected and feel safe. So thank you for those. I think what we'll do is we'll do Senator Dingra's presentation on the legislation session wrap up, which maybe saying wrap up's premature now that we have a special session running, but Senator Dingra will present, and then we'll finish with, I'll read the public comment that we received at the end of the meeting, and then we'll close. So let's turn it over to Senator Dingra.
Thank you. Good afternoon, everyone. I'll just say, yes, we are in a special session, but the Senate has done its business, not just the House voting. And so we should be done. I called 3 o'clock. I may be wrong, but I'll just say before 4. I don't have a formal presentation with a PowerPoint, but I did want to go over the work that we have done in the legislature this year for behavioral health, and to specifically call out the bills that relate to the work that we are doing here. I'll just start off by saying that definitely the last 3 or 4 years, the budget that we have voted on has been just this amazing budget in terms of making dollars available for the work that we're doing in behavioral health. One of the issues and the biggest barriers is workforce, frankly, because it's very hard to hire enough people to start new programs. And so I do want to acknowledge that and say that we'll cover some legislation we've done on workforce issues as well. So with that, I'm going to go through a litany of bills. Feel free to ask questions as I go through them. And then also happy to answer questions at the end of this. So the operating budget made about $1 billion in investments in behavioral health. That's what our budget has. And it is a really robust budget in terms of behavioral health. And on a side note, I'll just say this is not including the investments that we have made in addressing children with special needs in our schools. And so that was a huge priority for us this legislative session. While there's a lot more we need to do in terms of helping children with special needs, I just wanted to say that there's separate buckets of money in terms of addressing that. So I'm going to start off with Representative Orwell's bill. I was hoping she would be here for this, but she's not. House Bill 1134. This was the follow-up to the 988 original bill. We talked about how that expanded this group, provided different deadlines, so we have more time to do the work. The bill specifically made sure that we created an endorsement, that's what we're calling it, for mobile rapid response crisis teams. And basically what that means is that if these teams are able to meet these metrics that we have put in the bill, they will receive additional funding. So it's going to incentivize basically a culture shift on how soon people need to respond and what they need to do. And that incentive is really tied to the dollar amount that will be provided to these teams if they meet these standards. We, as already was mentioned, is doing dollars in collaboration for more training among the different groups and really making sure that people receive the training that they need, and then this collaboration and cross training between different providers in this field. We do put in specific dollars and have Department of Health develop a social media campaign around 988. You know, we were very careful not to create a lot of information right in the beginning because we didn't want the system to be overloaded and for people not to have a good experience when dialing 988. And so I think now we're in a position, thank you to everyone who's been doing this great work, that we can start ramping up more of getting the word out about 988. So we have specific dollars in there to do that. We did establish liability protection for several of the entities involved in doing this work, similar to the liability protections that exist for 911. And law enforcement are really making sure that 988 and responders to 988 have the same level of protection. And then, of course, the dates that we talked about, where we are changing those dates for CRIS committee work and on the technology platforms and those kinds of things. So that was the 988 bill. Thank you to everyone who advocated for it and testified. And I'm happy to answer questions on this bill, and otherwise I'll just move on to the other bills. So I'll just respond as soon as I see some hands up. Okay, the next bill that was related to the work that we had done there was my bill, Senate Bill 5120. This was the 23-hour crisis relief centers. I'll say the funniest comment I got on this bill once it was filed is when someone emailed me and said, "Senator, why are they closed for an hour? Is that a dinner break?" And so, I thought they were joking. They weren't, when multiple other people asked me, why aren't they 24 hours? So we decided to drop the 23 in the name of the bill because it truly was confusing people. So the crisis relief centers, as we're calling them now, the 23-hour and 59 minutes crisis relief centers. That bill has passed. It was signed. Thank you to everyone who went for the bill signing. And this really is about ensuring we create these centers where you don't need to have medical clearance. And it really is about not having exclusionary criteria. So really making sure we have behavioral health individuals trained in de-escalation, making sure they're able to do medical clearances. And so I'm very excited to see these up and running. Kirkland is going to be opening one soon enough. And I had asked if maybe we can all go for a little tour to go check it out when it's up and running. And so I was very excited to have that bill passed as well. The other bills that I will mention that relates to the work that we are doing was a bill I sponsored called 5300, which is really about ensuring that those individuals who are prescribed medications for serious mental illness, that their medications aren't changed on them when they change plans. And this is something I've heard over and over again, where people said they destabilized because they were forced to change their medication because of a change in insurance, or because unbeknownst to them, someone else, normally it's the insurance program or someone in between, decided to give them a generic versus the medication they're on. So hopefully this will help in creating more stability for those individuals with serious mental illness. The other bill that I had, and I'm sorry, apparently I have 3 bills listed one after the other, which were all mine, was one of the tours that we did when we went to DESC, when Rep. Orwell and I had done the tour around the state to check out facilities. And what we had found there is that DESC was using occupational therapists as part of the mental health teams. except they weren't able to get reimbursed for those services. They were using county dollars for that. So we passed a bill based on the feedback we received from DESC, which basically says that occupational therapists are now part of the mental health system. So their services can be billed and they can be part of mental health teams moving forward. This was identified as a critical piece in ensuring people actually learn the skills to kind of take their meds and daily living, and hoping that they can continue to stay in their homes rather than needing to go to a hospital. And it was also identified that even when they are hospitalized, it's actually very helpful to have an occupational therapist work with them to make sure they can continue when they're discharged from the hospital, to continue with their regimen of daily living. We mentioned True Blood and forensic competency restoration. There was a bill we passed trying to address that issue and trying to see how we can get people restored out in the community as well in the jail setting, and then again at the state hospital. So those were specifically around mental health. The next few I'm going to talk about are the behavioral health workforce. So Representative Levitt had a bill about adopting the Mental Health Counselor Compact. And these are the national compacts so that people can sign up and then they can practice within different states. And so kind of hopefully helping us making it easier for behavioral health specialists from out of state to move to Washington and work here. Senator Trudeau had a bill that ensures we're creating a certification for behavioral health support specialists that can actually be part of a workforce. This was a program that UW had started, must be 4 years ago, because our youth are graduating this summer with this degree. It's a bachelor's level behavioral health support specialist degree. This is a model that's been working very well in the UK for a while. And we really wanted to make sure that we're creating options for individuals to practice in this field that have something less than a master's degree. So this bill was signed, and I'm looking forward to Department of Health certifying all and providing licenses to all of these new graduates so they can enter the workforce. We had a bill that you should all be familiar with, and thank you again for your advocacy on this one. This was so Senator Emily Randall had this bill this session, the peer specialist bill. And I know that's one that we've talked about a lot about this bill, and that's been signed into law. And so again, really hoping that we can utilize our peer specialists to help out in this arena. And we saw that again when we did the tour in Phoenix on how they're utilizing peer specialists in all aspects of our behavioral health system. We also had a bill by Jessica Bateman that really takes a look at behavioral health providers in this field and kind of making sure we can get them working and their licensure done as soon as possible. So those were all of the big bills that we passed. In terms of the budget, I want to just stress that there's funding provided for crisis relief centers, capital dollars. So if across the state, if there are providers that are interested in setting up a physical crisis relief centers, there are actually physical dollars to do that capital work. There are also dollars for the operating in the budget to do that. This is through a grant program through Commerce. So anyone who's interested, please make sure you figure out how you can apply for those. In terms of youth work, I actually made dollars available are put in for our youth bucket to have dollars available for youth crisis centers as well. And I know that is a place where we really need a lot more resources. So there are dollars being made available. It's now up to the providers if they're interested in doing this work to utilize those dollars. We've done a lot more work in terms of housing that I think helps the population we're talking about. And again, lots of work around supportive housing, affordable housing. Through the Blake bill, we provide a lot of housing vouchers for individuals who are struggling with substance use disorder specifically. But, as we all know, they're co-occurring disorders. I know we don't use that term anymore. But really making sure we have access to housing vouchers for individuals to get off the streets and into housing. I was hoping we could have done a trailer bill on assisted outpatient treatment because we had heard from providers that this is really not working very well in certain parts of our state. That bill died in the House. And so I think that's something we can continue to work on. But I'm really interested again in making sure that assisted outpatient treatment is an option for people in our community. Right now, only King County and Pierce County appear to be utilizing this. So lots more on this. We have lots of dollars we made available to youth housing outreach, as well as ensuring we are opening up a lot of the community beds that construction had started on a few years ago. So in Clark County, we should have a whole bunch of beds available for civil commitment or a true blood population. Very excited about the UW Teaching Hospital opening up soonish. And I think that provides two great resources. One, in ensuring that we are training the next generation, and we know that when individuals go to college in that area, we have the ability to keep them after graduation. And with a UW Teaching Hospital in behavioral health, I'm really hoping that's going to increase our workforce. And the second is that teaching hospital means that they're actually treating patients while they're learning. So really expanding capacity for individuals. So really making sure we're taking care of the providers as well as the patients on that. And that continues to get closer and closer to completion. So I am actually going to stop there, since I know there was a lot of information that I threw at everyone. And I'm happy to answer questions about any of the bills, about any of the budget asks, and any other questions people have about the legislative process or anything in regards to that. I do think our House members can be joining us shortly, because I think they just took a vote on the bill, because my inbox is just pinging all over the place now. So maybe we'll have the opportunity to hear from Rep. Orwell as well. Okay, did you want me to call on people, or did you want to do that, Jamie?
I can do that, and you can be responsible for content. How about that?
Sounds great.
Okay, so and I just want to let everyone know we're going to need to wrap up by about 2:55, so I can do the public comment that we have, since we have that commitment. But we'll take as many questions as we can until then. So Claudia and then Kimberly. Claudia?
Say thank you, Senator, for your leadership in this session. We couldn't done better with behavioral health. You did an incredible work. So I want to say thanks. I was involved in a lot of the bills, but one part that was not clear to me was when the ability to people who come from another state to be able to practice in here. Is that only for behavioral health specialists, or the advocacy went to SUD providers, licensed mental health therapists? I don't know that little piece. Do you know?
Yes, so when we do these compacts, they are very specific to a very specific license. And I'm glad Department of Health is here, because they can pop in anytime. So this one was very specific to that particular license. That it's
behavioral health specialist, probably.
Yeah, so if you have that license, then that's what you can do it for. There are different compacts for different licensing, like there's a nurse compact, there's other ones. So this was a very specific one, and it's called the Mental Health Counselor Compact. So if your license complies with that, then people will sign up on that to make sure they can travel within states and then not have to go through a new licensing process.
Would be great from the Department of Health to get clarification, DOH, because that might be applicable for licensed mental health therapists. So if we get a little clarification when Department of Health join, that would be awesome. That would really help. And then I just want to say for the bill of related to peer specialists, one big victory is their ability to bill. It's a long-term bill, but in a couple of years from now, it's the ability to manage care, giving us specific ways to bill for that service. And that was in the bill, and that's an incredible victory because we had never been able to bill for peer specialist services. So thank you again.
And I'll just add on that bill, it got really contentious because there were some people who thought that they could no longer provide or do the work that they were currently doing. And I just wanted to clarify that. We don't take away anyone's license. The people who are currently peer specialists can continue to be peer specialists. This is an add-on. So you basically have a pathway to continue doing the work you're doing right now. You can then become a specialist, and then you actually have a pathway to do more things, become a supervisor, do training. And as you said, really making sure you're able to bill for that service so that we can basically have them in emergency rooms, part of a crisis mobile response team, like you name it, and really making sure we're utilizing peers at every step of the way.
I'm going to ask Claudia. Claudia, I'll give you Michelle Roberts' email. I'll ask you to email your specific question about clarification directly to her, because it's going to be someone else within her department that'll be able to answer that. And she'll route that. Kimberly.
Thank you, Senator, for your remarkable work. And even thank you for your failure. I was really sorry, of course, that AOT didn't do better this session, but you have been a tireless advocate for expanding AOT in Washington. I'm personally grateful for that. You've heard me during this call talk about the rather unfortunate situation with folks in our local communities who are falling into our criminal justice system because of crimes committed and our inability to find outpatient solutions as an alternative to incarceration. And I think AOT is part of that solution. So thank you. Keep trying. Let us know how we can help. You mentioned something about housing vouchers as part of Blake. I wasn't familiar with that part of the legislation. Could you talk about that a little bit more, please?
Sure. So, and I just mentioned Blake because, of course, I assume you guys follow everything the legislature does. I know it's not true. But Blake was that lawsuit, Supreme Court decision 3 years ago that found our drug possession laws unconstitutional. We came into special session right now to make sure we're addressing drug possession. And part of that bill, we also set up an infrastructure to provide more services and support for individuals dealing with substance use disorder. And we do know that the crisis work we're doing here connects with that, because as we know, a lot of people who have serious mental illnesses do self-medicate with drugs. So part of that is we're expanding LEAD. This is the program that law enforcement can refer individuals into for services and support and treatment. That's going to be expanded to try to be as much available throughout the state as much as possible. We have Healthcare Authority that has a substance use navigator program, again, expanding that so that, again, every region has someone who they can refer to who can help them get services and support. The other component on that is really making sure we're providing housing vouchers. So we're not necessarily building new housing, but saying that you can contract with current housing, you can, as creative as people can get in terms of making contracting with local housing providers so that people can get vouchers, a 30-day voucher, 2 weeks voucher, whatever that may look like. So you can get them off the streets. There was additional funding in there for crisis relief work, a lot of dollars to help address the crisis system. And, that's really how we're getting to $1 billion in funding for the work that we're involved in.
Okay, we probably have time for one more question for Senator Dingra, maybe two. Any other questions?
I'll just say one more thing on AOT, because you've heard me say that for years and years. I do think we're very close to passing it. It comes back to the Senate, to the Rules Committee, and so hopefully we can get it across the finish line. AOT, this bill in front of us is when we did assisted outpatient treatment, oh gosh, last year, one of the big things we did in it is ensure that people other than our designated crisis responders can file an AOT petition. The reason why this is critical specifically for our state is that we're actually an outlier in which we require DCRs to do the petition. A lot of the states have a wide variety of individuals who can do that. And our AOT law last year actually allows for an expansion of those individuals who can file AOT. And it's critical that we see that in use to see how it shows up in our state, because a big barrier is our capacity for DCRs to do this work. As you've heard, it's very, very tough work with very limited resources and very few individuals who are doing this work. So that's a big component of it and a big shift in our state. So I think having a trailer bill to make sure it's implementable is going to be key in providing more access to outpatient treatment in Washington. Okay, well, thank you all so much. And just remember, I know we just ended, but it's in a month, it's time to start working on legislation for 2024. So get those ideas going, get those thought processes going, and let's just start collaborating on 2024.
Sure, we came up with lots of fodder for those thought processes in our discussion today. So Senator Dhingra, thank you so much for preparing this presentation and for making it here to share with us, and for all of your work this session on behalf of behavioral health. All right, I have one public comment to read, but before we do that, we'll quickly do action items and next steps. The biggest action item is to synthesize and format all the why responses today in our root cause discussion and send that back to all of you. As I mentioned when it came up in our discussion, Nicola and I have the recording and all of the great notes that she took during the discussion, but we're also going to be counting on all of you to review it and let us know if we misinterpreted something or put it in the wrong place, or you see it differently, so that we can make sure we have a strong accounting of what we talked about today, because we do want that to inform, as I've said a few times, HCA's strategic planning coming up, as well as future deliberations on recommendations to start filling the gaps that are within our control. Nicola, are there any other action items that I missed?
No, I think you captured it, Jamie.
Okay, great. Well, let me just, we have one person who signed up for public comment, and they have asked actually that that we read it for them. So this is from Rochelle Madigan. I'm going to read the public comment. Really enjoying the conversation around complexities related to stigma. Was grateful to hear someone, Kim Hendrickson, and with a question mark, remind everyone that people exhibiting violent criminal behaviors in crisis are still have needs and deserve to have those needs met. In that same vein, as we move to a more supportive, less punitive model of care, we also need to have a plan that includes restrictive measures when they are expressly needed to keep an individual and the community around them safe. My child is extremely assaultive when he is in crisis. This is not because he is an evil person. It is because his complex intellectual disability and mental illness prevents him from using coping skills sometimes. Without careful planning and implementation of, in parentheses, at times restrictive measures by those around him, he would surely have already committed murder and sexual assault as a disabled 15-year-old. Crisis responders need to have a way to manage assaultive or injurious behaviors safely. An important piece to consider with regard to youth crisis stabilization is that as we move towards stabilizing children where they are in their homes whenever possible, we will need to have a culture shift that educates providers to listen and respond appropriately to parents and caregivers. As a parent of a child on the extreme end of need who presents danger to self and others when dysregulated, I have experienced a lot of trauma because of providers using blaming language, obviously not listening to or believing me. Parents and caregivers often have the most expertise about behavior patterns and what works and doesn't. So trauma-informed language and rapport building with the family is critical to the outcomes for kids. Currently, the statewide culture between parents and providers tends to be very us versus them. We need to move to a we culture if we're going to be successful with MRSS. Okay. And that is it for our public comments today. So everyone, thank you so much for your patience today, particularly around the late changing agenda items. But I'm really glad we were able to have Senator Dingler with us today. I'm really glad that we were able to have that extensive conversation on root causes. And we will see you at our June meeting. Everyone, in the meantime, take care. If you're in the Seattle area, enjoy the sunshine. I don't know what it's probably sunny across the state. Enjoy it all over the state. And we'll see you next time. Take care, everyone.